amlodipine has no outcome trials as such as for myocardial infarction mortality. And therefore, it's a good combination, yet the benefit is nothing to do with the blood pressure. Blood pressure was exactly the same. The benefit is very much related to the ACE calcium. Okay, I'm done. I think I did it in 10 minutes. So I think in optimizing your treatment, the choice, we use monotherapy, double therapy, triple therapy. I think the point is we need to optimize our treatment in patients. Triple therapy. I think personally, I use combination in smaller doses to try to sort of take care of multiple mechanisms in hypertension. And here you can use an ACE and a diuretic and a calcium channel blocker. And I think the main aspect is to reduce mortality, reducing mortality. So let me conclude by saying that if you are treating hypertension as hemodynamic changes and you want to achieve a good number, you can use any of these interventions. All work. But if you are looking at the vascular aspect of things and we need to alter vascular damage, then I think we need to be looking at an ARB, an ACE inhibitor, or an ARB if it doesn't work, and then you can add. But I think the base aspect is using something that can prevent mortality and morbidity. And as Sir William Osler said, a man is as old as his blood vessel. I think we need to maintain a good vascular health. Thank you very much.
Can I just interrupt you, Dr. Rashid, for a second? We have in Hall B a plenary session for nurses and technicians especially. This is how to prepare a patient for cardiac CT and optimizing a CTA scan and post-processing tips. So please, if they would like to join that session, it's open now. Thank you.
Thank you, Dr. Hisham, for your nice hypertensions. We are running a advanced schedule, so we have to make 20 minutes each sessions. Our next speaker is Dr. Yasmin Hanif. She's the consultant cardiologist at Dalla Private Hospital. She came from Saudi Arabia. She'll talk on CMR for the right heart and beyond. Welcome.
Thank you. So I'm going to talk about cardiac MRI, and I would like to start to say that cardiac MRI is an advanced modality, and if I can say that it's a combination of cardiac CT and echocardiography. We do functional assessment, we do Doppler assessment in terms of velocity measurement, and also we do static images, and also we have a superior acoustic window. And in a minute, I'm going to talk about CMR assessment for the right ventricle. So that's it. So we're going to talk that right ventricular assessment by cardiac MRI. And why is that? Actually, nowadays, the gold standard of assessment is cardiac MRI, superior to echocardiography, and actually having a lot of information beyond the functional assessment. Cardiac MRI, as I said, superior acoustic window, and it's free of ionizing radiation. Rather than having a cardiac CT, you can do a cardiac MRI free of radiation, and you could have all the data going on. Why is that? Actually, when we do plan cardiac MRI for right ventricle, we got to have this specific views, long axis views, and we have short axis in the stack. Oops, okay. And short axis in the stack for the functional assessment and also the circumferential regional wall motion assessment, and then transaxial cine stack. No right ventricular assessment going on without transaxial cine stack. And that's also for the regional wall motion assessment, especially for ARVC. ARVC equal transaxial cine stack. And if you want to add for the congenital assessment, we can run also the cine stack, but it's not transaxial, it's going to be coronal views. Okay, so here is the basic views. Dr. Vamil already explained that's 4-chamber view. And for the one who's not doing MRI, well, we take the short axis, we plan it, we try to avoid the LVOT, and we cross the apex here, and we produce this image. So right atrium, right ventricle, left ventricle, and left atrium here. Okay, so this is 4-chamber horizontal long axis view, you could say. And next, we do 2-chamber for the right ventricle, and simply we just, from the 4-chamber view, we cross-cut the tricuspid valve, and we have 2-chamber view. This is for the regional wall motion assessment, and this is essential view, because if you take a physiology of right ventricular contraction, it's in a longitudinal axis rather than a circumferential or radial axis like the left ventricle. So 2-chamber view, it's going to look for the regional wall motion assessment. And next, this is the right ventricular outflow tract. As I said, this is basic view. You cannot get away with it. Okay, so RVOT. Why we're picturing RVOT? The right ventricular outflow tract is a muscular band, and it participates a lot with the ventricular contraction and RV function. And we see that with tetralogy fellow. When we have akinesia after the surgical repair, we expect that we have low ejection fraction in the right ventricular function. So RVOT is a part of the right ventricle, and it participates in right ventricular function assessment. So we got multiple planning for this view, and the simplest is that you go to the main and we cross-cut, and you produce this image with the pulmonary valve is in here, and the main part, and this is the RVOT area, and this is the right ventricle. Short axis in views, and this is what we're going to look for. We got multi-slices, and starting from the AV groove, mitral valve, tricuspid valve, starting from the base of the heart, if you could say a bit base of the ventricle, toward the apex with 1 centimeter leading edge. This is for the right ventricular assessment, an ejection fraction. If you are looking for more specific pathology like VSD, and we can change the interval actually, but basically for ejection fraction assessment, we keep this 1 centimeter leading edge. So base of the heart to the apex, I see the mitral valve, tricuspid valve, and I get this images. This is the base, this is the mitral valve, and I expect to see the tricuspid valve toward the apex. You don't skip the apex actually, because it has volume, and this volume is going to affect your ejection fraction assessment. Next, the transaxial cine stack that I was previously talking, any right ventricular assessment, ARVC, transaxial cine stack directly. So it's what we're going to see here. There's a 4-chamber view actually, but we're going to take a coverage from the heart from superior to inferior. So we start with the pulmonary artery and we're going downward inferiorly. And we are actually assessing the regional wall motion differences in each slices. So it's very specific, and with experience, you get to learn if there is dyskinesia or microaneurysm that affect the right ventricle in terms of ARVC. And additional information that you get it when you acquire this image in the transaxial cine stack, you get to know other pathology that can affect the right ventricle, which is a superior vena cava anatomy, if that there is an extra pulmonary vein going to the superior vena cava, if you have an extra SVC, which is the left SVC, and also we get to know the ascending and descending aorta where we have right-sided arch, which is completely asymptomatic. Most of the patient they don't present with any symptoms, and you get right-sided arch, and this is important for surgical planning afterward. Here we're going to start a case, live cases, a patient referred for an ECG change. He has a history of chest pain, ECG, ST elevation in anterolateral lead, with ST depression also in inferior lead. Echo assessment show that, oh, we have reduced RV volumes and transthoracic echo. Please answer us. What is it, the right ventricular volume? In MRI, we go and answer the clinical question. You get a lot of information, but you have to focus on the clinical question. So what we did, this is a cine image. I think the anatomy is here is the left ventricle, right ventricle. Anything abnormal? Just shut, excuse me. Right ventricle, what? Exactly, very nice. So this is the lateral wall of the left ventricle, and it's kind of hypertrophied rather than the normal size. So if I move to the next step, and then we went further, and then this is another view, 4-chamber view, as I explained, and we see the lateral wall of the left ventricle. It's really hypertrophied. 60 millimeter is quite above the normal value. And what else? What do you think wrong with the right ventricle? Usually you see trabeculation in the right ventricle, but this amount of trabeculation is quite abnormal for the right ventricle. So from this view, we can establish that we do have lateral wall LVH along with right ventricular hypertrophy. So after assessment, looking at the right ventricle is hypertrophied, and then we did the volume assessment with the CineStack, and we found that we have really high normal ejection fraction. So it goes with the RVH. So RVH and high normal ejection fraction. So we established some differential diagnosis. Maybe we have an anatomical structure that could lead to RVH, which is pulmonary valve stenosis, and you can get the answer out of cardiac MRI. We did the assessment. I'm not going to, waste the time, but there is no pulmonary stenosis for this patient. We did the transaxial CineStack also because we had an ECG changes. If we didn't have the ECG changes, we wouldn't think with the RVH that he might have any RVC. But in case of ECG changes, this is the first sign of ARVC, so you got to go through the RVC protocol. So that was not the case for this patient. So we concluded, this is a late GAD enhancement actually, it wasn't really abnormal, but with reservation for the right ventricle. Late GAD enhancement is not really accurate for right ventricular assessment because it's a very thin wall. In this case, it's an RVH, but even though it's not reproducible to report the late GAD enhancement. The final report is that we have LVH, an RVH, and high normal ejection fraction for the right ventricle, and we asked the clinician to further investigate. We didn't have any anatomical structure that caused the RVH, and either the late GAD enhancement for the left ventricle to cause HCM. So further clinical assessment was concluded. Next case. Okay. So this is the short axis CineStack that I've previously explained. And if you go to see those two images, this is the papillary muscle, as I previously explained. This is a mid-ventricle. And in this level, okay, I can see the right ventricle here. It's kind of enlarged in comparison to the left side. You do agree with that. And the next slice here is If you look at the slice location, actually it's really small letter, but this is 40 and this is 60, so this is more apical. And when I go to see apical view, I can see a structure here and a structure here. And those structure, retrospectively, is the tricuspid valve. So why am I seeing the tricuspid valve at this level? It's beyond the mid ventricle and it's going toward the apex. So what is the pathology could be? I'm not going to say it now. And if I go further, this is another view that we acquired. This is the RV in and out view, which is the tricuspid here, the N, so tricuspid valve, and the pulmonary valve in here. So what is it? This is the anterior leaflet of the tricuspid valve, and this is the posterior leaflet. So anterior leaflet is here, the origin of the anterior leaflet, and the posterior leaflet is quite distal. So are we close to the pathology? Any guessing? Exactly. So this is a 4-chamber view, and you can say this is I think this is the anterior leaflet again, and this is the septal leaflet. So we get posterior and the septal leaflet are quite distally to the apex, and you can see some malcoaptation in this valve, and the atrium is quite enlarged, which is expected. And this jet is, oh, I couldn't say a jet, but this is a dropping signal in terms of cardiac MRI, and that suggests more or less a regurgitation going on. So what else we did? We assessed the ejection fraction, and the RV volume is 210. That's quite significant for the patient, but the ejection fraction is 60%. And I will be reserved on that ejection fraction, and I will explain myself later. So later on the same view, the 4-chamber view, this is another imaging, which is equal to echodoppler, I could say in simple term. And this is the leaflet, and this is the jet that I was expecting to have a regurg, and it's actually a regurg, and I have 2 backward jets in here. And that could be what? A tricuspid regurgitation. So went further, optimized our imaging, and then this is one jet, and this is another jet. I hope you do appreciate that. So we have 2 multiple jets related to abnormal pathology of the tricuspid leaflet. We calculated the volume. Here is it. We have a visual assessment of the length of the jet, and we don't have quantitative data, but in MRI you have a quantitative data. And in this patient, we did the evaluation through certain acquisition. We do the pulmonary forward flow, and then the RV stroke volume, and then we divide it by 100%, and we get the RV, the regurgitated fraction volume. And to be severe, it's 50, and for this patient, it was actually more than 50%. So severe TR with Epstein abnormality.
We have 5 minutes more.
5 minutes? Oh, no. I don't think I can finish in time. Okay. I'll move to the next case. It's actually a patient, oops. So this is a case of 10 years old male, referred with history of perimembranous VSD and subaortic membrane. They get an impression of double chamber RV. And actually, if you look at retrospective, this is a classic presentation. Subaortic membrane, you gotta have a double chamber RV. So what is a double chamber RV? It's a very congenital heart disease. And we did plan the MRI, but we're not going to look for the perimembranous VSD or the subaortic membrane because this has been already established. We are going directly to the clinical question. Clinical question whether there is a double chamber RV or not. This is what we're going to plan for. So this is the transaxial sinus stack I was explaining earlier. So starting from the aorta here, the aortic root, You can see some VSD, but this is not my point. You can see some high systolic jet in there. And then you go further down, and you can see further the jet in here. And there is some notch coming out here and notch in here, okay? Further down, and you can see a muscle band in here, a muscle band in here, and this is high systolic jet in between. So, short axis view again of the same transaxial cine. So we did a crosscut, and then we acquired this. Two muscle bands in between. There is a high systolic jet, and this is a diagnosis of a double chamber RV. So we confirm the diagnosis, we give them the answer. I don't have a time. It's going to be generous. So I'll move to the next case. Is a double outlet right ventricle already repaired with the aortic coarctation. It's a rare congenital heart disease for the double outlet right ventricle, but why the patient is referred is not for this pathology. His MRI, and you do appreciate the size of the RV, isn't it? It's quite enlarged, significantly dilated. You can see the septum itself, the left ventricle. So there is a septal displacement, and this is essential sign in case if you have RV pressure overload or RV volume overload. This is a significant sign you have to keep in mind. So in this view, RV is significantly dilated. Next. Also, there is a moderate RVH, high trabeculation, and sorry, okay. I want this to play again. So this is another view of the pulmonary artery. It's quite rounded here and is significantly dilated. For a normal pulmonary artery, you don't see it this side. And this is another cross-cut of view of the pulmonary artery in transaxial cine. This is usually dilated pulmonary artery. And this is an indirect sign of a significant pulmonary regurgitation, that the pulmonary artery is trying to adapt this high volume coming off, and you get to look for the reason. And it's a pulmonary regurgitation is there. And this is the view, the RVT view. This is a modified RVT view. And you see the systolic jet coming off, and then there is another jet coming downward. And this is, if you could say this easily in MRI, that means severe PR is going on. That confirmed that RV dilatation, we calculated the volume itself, and we did also our assessment of the PR. And this patient had, I think it was 72%? Yeah, 72 if regurgitant fraction. Usually it's 50%, and more than this is severe. So he has severely dilated RV consistent with severe PR. This is a very interesting case. Okay, playing the cine itself. I think now you're more than experienced to say that this is dilated RV, isn't it? Then what else? Is it good RV or bad RV? It's a very bad RV, okay? What else? Here. This is a pulmonary, this is the lung, and this is the lung also here. And what is this? Pleural effusion, exactly. So I have bad RV, dilated. This patient came, actually asymptomatic, for a tetralogy fellow assessment for the right ventricular function. He has a bad RV, seriously bad RV, and pleural effusion in the right side. And then we went further. This is the coronal views, and you can see again the pleural effusion is not easily to be missed. It's more than moderate. It is massive pleural effusion. Bad RV, pleural effusion. What is it? A sign of what? Okay, heart failure probably. Okay, so, and then, as I said, that patient already had repaired tetralogy fellow and was following up his right ventricular function. And to keep in mind, this black dot here is a stent in the pulmonary valve, which is usually those patients get repaired after the tetralogy fellow with the stent in the pulmonary valve. So this is the right ventricle, this is the pulmonary valve, this is a stent. And we did about our velocity mapping, and then I can see only small, tiny jet coming across the stent. When we measured this jet, actually, in Vmax, it was 2. So it couldn't be. That narrow jet, very small, fine narrow jet with high velocity in a bad ventricle, that doesn't make sense. Why is this ventricle having a poor function and high gradient across the valve? So we suspected something. What is it? Any guessing? RV failure, a small narrow jet in the stent. So what is it? Any guessing? No, it's not, Sean. Something wrong with the valve. This is a very small narrow jet. So another view here. That's a cross-cut of the view. And this is the white, the bright signal is the only jet coming across the stent. It's supposed to be larger than this. So we suspected there is a stent stenosis. We couldn't establish that. We referred the patient urgently for echocardiography, and we found out that the patient has a vegetation through the stent with significant pressure across the valve. So he was pushed in emergency cardiac cath to have a balloon dilatation. And afterward, he was treated in intensive care for his right-sided heart failure and further for the endocarditis treatment. Unfortunately, the course wasn't really good for the patient, but the point is here that MRI is, if you really understand and you know what you're looking for, you could establish a lot of pathology like endocarditis in MRI. This is, not really was designed for, but actually with high index of suspicion. This is the pulmonary stent, this is the narrow jet I told you, and this is the cross cut of that jet. And with the help of echocardiography, we established a diagnosis. So I think I'm running out of time. Is that? Thank you very much. See you in the next speak.
Thank you very much, Dr. Yasmin, for the nice presentation on the CMR for right heart. Our next speaker is Dr. Amrish Agarwal. He is the consultant cardiologist from Fujairah Hospital. He will talk on assessment of right ventricular function by echocardiography. Welcome, Dr. Amrish.
Maybe the rest of it.
You have a VGA? VGA dongle. Bring your laptop. Sorry about the excuse. Actually, we had a very, very excellent talk by the previous speaker on the MRI assessment of the right ventricle. And they were mainly dealing with the congenital heart disease. But as you all know, bring the laptop. As you all know, the MRI is a very tedious process. It takes long time for the patient to be inside the machine. And echocardiography is a far more rapid tool to assess the function of the heart. Actually, for years, we all cardiologists have focused on the use of the, just give us a second, and we have to do circulation. So this tells you backup is very important. It is in your pocket, you know. Enable content. No, the enable contents will not play. All right. So for years, we cardiologists have focused on the left ventricle, and there are numerous articles and papers and lectures. We tend to speak in the meetings how is to assess the left ventricle. But over these times, we are actually realizing that the right ventricle is also very important. It is just not the innocent bystander, which we tend to believe. It is actually a very important component for the function and prognosis and the outcome for many of the conditions which actually affect the left side of the heart, such as myocardial infarction, heart failure, valvular heart disease, congenital heart disease, particularly when we assess the RV function, pulmonary hypertension, and certainly after cardiac transplantation, considering that in UAE, a good number of patients are undergoing cardiac transplantation either inside UAE or outside UAE for him. There are numerous challenges which we cardiologists face when we try to assess the right ventricle by echocardiography. First of all, unlike MRI, which can assess the whole chest in the single cut, the right ventricle, the echocardiography has limited views because we can really only assess the heart by looking through the ribs. And the right ventricle is a thin walled chamber behind the sternum, and hence, to comprehensively image the right ventricle, several views are needed. Second of all, the inflow and the outflow portion of the right ventricles are in separate plane. This makes the life of us as a clinician a little more difficult. Third of all, the right ventricle is a thin walled chamber and is heavily trabeculated. This makes us difficult to define the endocardium, where the endocardium starts and where does it end. And hence, over these years, we cardiologists has got numerous articles and papers published regarding, and different cardiologists, different views, what is normal and what is abnormal. And I would like to draw your attention to two views, two articles which are published. One is Journal of American Society of Echocardiography in 2010, which actually totally is focused on the right ventricle assessment. And second, the article on the European Heart Journal, Cardiovascular Imaging, which is actually an article on quantification of cardiac chambers. A big component of this section is about right ventricle by itself. So the question comes as that, how do we assess the right ventricle in the clinical practice? And the answer is, it is not very easy, because in order to just image the right ventricle, forget about assessment, there are 14 views which are described. And if a cardiologist wants just to image the right ventricle properly, he will have no time for the left ventricle. And left ventricle assessment is what we are looking in the clinical practice in the general population for him. Methodology, how do we examine the right ventricle in the clinical practice? And for you clinicians, I can give you some tips that we have to look two views, the short axis view, parental view on the short axis, and we have to look at the four chamber view, which is actually a apical four chamber view, but we can tilt in such a way so as to image the right ventricle in the center of the image, and this is called as a modified right ventricle apical four chamber view. Actually, a number of dimensions can be taken from the right ventricle by echocardiography. When you assess the right ventricle by the four chamber view, the American Society has determined you can actually measure the dimension of the right ventricle at the end diastole, at the base of the tricuspid wall, as in the middle of the sections, and the cutoff values are mentioned as 41 millimeters and 35 millimeters respectively. But these dimensions are determined for the American population, and we all know a typical American, even the shortest one is 5.8, and this is the maximum height where the Asian people can reach in general population for him. Similarly, when you take the parasternal views, we can actually look at the right ventricular outflow tract, and the cutoff is which it determines are 30 and 35 millimeters in the general population. However, European people, when they looked at their own population, they found their sizes are smaller, more of a typical Asian in size, and the cutoff values, as you can see, are a little bit on the lower side, was a 35 millimeter, the American document is a 27 millimeters the European documents, and hence overall diameters are actually a couple of millimeters lower than the American population. So it appears to us that overall it depends which ethnicity we are looking at. And particularly in Middle East, where the human population is more of European size than the American size, this European document size are actually of more relevance to us in the general population. And I will recommend you to use this dimension in the practice. So in summary, if in a parietal view, you find anything which is more than 25 to 28 millimeters, this really indicates the right ventricle is dilated. And in the fourth chamber view, if you find at the base of tricuspid wall are 33 millimeter and at the middle of the right ventricle 27 millimeters, this may indicate the right ventricle is enlarged. So you may say, are we going to spend a lot of time in really assess the right ventricles? So we can actually look a little bit quick and dirty way how to assess the right ventricle dilatations. For example, you can look in the fourth chamber view, and if you find that the left ventricle is actually bigger than the right ventricle, this may indicate the right ventricle is actually normal in size. But if you look and you find that the right ventricle is more dilated than the left ventricle, I'm sorry, because the images are running with the memory stick, they're not running very smoothly. So you will find that the right ventricle dilatation is similar or larger in the left ventricle, and this means the right ventricle is dilated. But one important point to look is the apex is formed by which ventricle. When the right ventricle becomes dilated, the apex is shifted in such a way that the right ventricle contributes to the left ventricle apex, what you see. So in order, when you see and you find in a modified fourth chamber view that the right ventricle is contributing to the apex, this means that the right ventricle is abnormal. Another thing which we can see, which is actually right, MRI is little more better, is to look at the thickness of the right ventricle. So a right ventricular thickness can be measured by the M mode, as you can see here, or also can be measured by the 2D echo. And if you find a normal right ventricular wall thickness is less than 5 millimeter, but is typically 3 to 4 millimeter. Anything more than 5 millimeter is abnormal in the general population. So right ventricular thickness becomes important when we are actually looking at the congenital heart disease, or we are looking at some condition like valvular pulmonary stenosis, where the right ventricular is hypertrophied. Another thing we can look is the fractional area shortening of the right ventricle. For example, if you have a lot of time, you can calculate the end diastolic volume and the end systolic volumes of the right ventricle, and actually you can calculate how much is the ejection of the right ventricle in the systole, and normal fraction shortening of the area change of the right ventricle is the tune of 35% or more. So the question comes to us, how do we, in the limited time, assess the right ventricle quickly and fast in the practice? So it appears that you can really assess the right ventricle, You can really assess the right ventricle not the same way you assess the left ventricle. For example, when you assess the left ventricle, you look at the left ventricular sphericity, you look at the contraction of the left ventricle by M mode, and if you find that the two segments are coming close to each other in the systole and diastole, this indicates the right ventricular contour is normal, and you can actually calculate the volumes and you can calculate the ejection fraction by the M mode. But the right ventricle is a little more tricky. Parameters are used in the assessment of right ventricle. For example, you can use M mode parameters, right ventricular diameter, which you have seen before, wall thickness. But one important component we can use an M mode by right ventricle is what is called as TAPSE. And what is TAPSE, we will see a little bit later. We can also use 2D echocardiography to see RV diameters, area and wall thickness, and the fractional area change. But like we said, this process is a little bit tedious. One can also use another method called as Doppler method, in which number of parameters we can assess, and we will see a little bit later. But among the Doppler parameters, the assessment of S wave is actually very, very important in the general practice. So our theme of the topic is that how do we assess the right ventricular systolic function? The answer is that we try to use in the clinical practice 3 parameters, and we in Future Hospital tend to use these parameters a lot. First is we use TAPSE. This TAPSE is nothing but tricuspid annular systolic excursion. So by definition, it means we are looking at the systolic excursion of tricuspid wall. Second is the S wave of tricuspid annulus. This is used by tissue velocity imaging and Doppler plus Doppler mode. And the third thing is a little bit complex, but it is actually not so difficult, is to calculate the TIE index or the right ventricular index of myocardial performance. So how do we do it? So before that, we have to understand how the right ventricle functions. As you can all make out, we are putting the probe at the apex of the right ventricle. This is where place you normally put the apex, the probe. And actually what we are looking is the displacement of the base of the right ventricle towards the apex. So in the normal contractile to the RV, what happens? The apex is actually tethered in normal place and is the base of the right ventricle which descends towards the apex in systole and diastole. In diastole, the base goes away, and in systole, there is a rise of the base towards the apex. So we can actually quantify this motion of the base of the towards the movement of the base towards the apex in systole and diastole. And this component, what we can quantify, is called as tricuspid annular systolic excursion plane, or what we call it TAPSE in the general population. It is actually a very, very simple thing to do. You just take the 4-chamber view, you try to make it a modified plane by bringing the right ventricle in the alignment to the M mode cursor. Just put the M mode cursor and put the M mode cursor crossing the annulus, and you can actually put the M mode and you can zoom it up, and this movement from the base of the annulus to the full movement excursion is called as TAPSE, and a normal TAPSE is 60 millimeters or more. In most of the normal people, you find TAPSE crossing 20 millimeter, in the range of 20 to 24 millimeters for him. For example, this another patient where you can see the TAPSE in the range of 19 millimeter. So this is a normal systolic tricuspid annular plane excursion in the population. There are a lot of advantages by using this method. First of all, it's very, very simple in the population to use. You can do it less than 30 seconds. And there are some disadvantages that it assumes replacement of us represents the function of the whole right ventricle in a 3D structure. It is angle dependent. Obviously, if you cut the angle wrongly, you oblique, you will cut the full extent of the movement. It is load dependent. So if you have a right ventricular volume overload, obviously the TAPSE will be exaggerated. And in the pressure overload situation, you will find the TAPSE is a little bit on the lower side. But the recommendation by society is that TAPSE should be used routinely as a simple method to estimate RV function. And they say the cutoff value is around 16 to 17 millimeters. So if you have a patient with a congenital heart disease or a patient with the right ventricular failure and you find a low TAPSE, this indicates that the right ventricular function is impaired. So apart from TAPSE, there are certain other methods which we can use. We have seen this TAPSE method, but another method which used commonly in clinical practice is by using tissue Doppler imaging and by putting the pulse Doppler and assessing the S wave. And this S wave can also be assessed as rapidly as TAPSE. It hardly takes less than 25 to 30 seconds in the general population. For those people who are not familiar with this practice, what you do is that you actually light up the right ventricle by using tissue Doppler imaging, and you use a apical 4-chamber view. Once you get a 4-chamber view, go to tissue Doppler mode, place the pulse volume, sample volume at the tricuspid annulus, or just little above to the middle of the basal segment of the RV free wall. And the S wave velocity is read as the highest systolic velocity without overgaining. Normal is more than 10 centimeters per second. So if you have a velocity of the base of the right ventricle more than 10 centimeters per second, this indicates the right ventricle is actually contracting reasonably well. There are certain advantages. Obviously, it's a very simple technique with a good discriminability, and methodology is available in the most simplest echocardiography machine. Does not require any fancy tools or software attachments to your machine. The disadvantage is that obviously it is angle dependent, and it assumes that the function of the simple segment represents the function of the entire right ventricle, and there is insufficient data in the elderly. The last part we use on the Doppler velocity is an index, which is called as TIES index. Now, what is the TIES index? It is nothing but similar to what we did before. So if you put an tissue velocity integral imaging and you put this pulse Doppler, you find this type of pattern, which is the S wave, and this is the A wave, and the E wave prime. So what you do is that you measure the interval, which is called an isovolemic contraction period, which is the time of closure to the opening of the S velocities. You measure one more interval, which is isovolemic relaxation period. So you can see these two intervals you measure. In addition, what you can do is that you measure the ejection time, which is actually the whole S wave from beginning to the end. Once you calculate the 3 parameters, it will not take more time. Once the practice develops, you can actually calculate the TIE index very rapidly, which is nothing but the ratio of isovolemic time. So sum of IVC, interval and conduction time, interval and research time divided by the ejection time. So these two parameters divided by these two parameters, this parameter give you an index which is called as the TIE index, and this is also very useful in the general population. So coming to the simplistic method we have seen, there are certain more parameters which we can use in the clinical laboratory. And what are those parameters? Obviously, those parameters are strain and straight rate imaging. Now, commonly, we cardiologists tend to use strain and straight imaging and the global load strain on the left side, but we can actually apply this methodology on the right side. So how does it work? As you know, the human heart has got certain parameters. For example, the right ventricle has got many echogenic particles which the echo machine can track. So what the machine does, it actually tracks the particles on the surface of the right ventricle and calculates how rapidly these particles come close to each other and how rapidly they go away from each other. So the machine digitalizes the right ventricular surface and tracks this particle and the motion between these two particles. Once it calculates, you can actually see that this machine can calculate these particles and encodes them. The more radar is the velocity, more rapidly these particles coming to each other, and you can actually put a values to it. For example, these values are range of 20, 18, and 15. So this indicates a robust RV contractility in the general populations. There are a number of clinical utility by using this methodology in the clinical practice, and we sometimes in our hospital do assessment of the right ventricle strain in our practice. For example, because I'm sorry about it, the image is not very, very good. This is a patient who has got an severe aortic stenosis and has got mitral regurgitation. And you can also see that the right ventricle is dilated, but the function of the right ventricle is difficult to assess by traditional echocardiography because it appears dilated. But you can see you may think that the annulus is moving and the right ventricle is moving reasonably well. So it is possible that this right ventricle has got dysfunction, but it is not severely dysfunction for him. So what you can do, you can actually assess the right ventricular strain by using speckle-based echocardiography, and you can see this in the range of -10, -15, -18, the apical segments, the mid segment, and the basal segments, and these strain values can be calculated on the free wall. Obviously, septal values are not very reliable because the septal values also depend on the left ventricular size and the function. So this is a little bit tricky, but the right ventricular free wall you can assess reasonably well. For example, another patient is a patient who had inferior lami, and actually he came with the primary angioplasty. So I took to the cath lab and we opened the artery, we opened the right coronary artery. But the next day we find the patient is still in cardiac failure, and the echocardiography shows that you can see, sorry, but you can see probably that the left ventricle is actually septum D-shaped, and this indicates the right side. And now you can see that the codex of this machine is not like my machine. The right ventricular function is affected, and the longitudinal strain is nearly -7%. This indicates significant RV dysfunction. So it appears we have another tool in our armamentarium to assess the right ventricle. There is another hemodynamic data which we can use to derive from the right ventricular function, and that is nothing but the systolic pulmonary pressures. And all of us in the room are familiar how to calculate the systolic pulmonary pressures. We use the Bernoulli's equation, and the RV systolic pressure is equal to the forward velocity of the tricuspid regurgitation plus the estimated RA pressure for him. But one important tip which you want to take home is where do you measure the IVC size to assess the RA pressure? The IVC size to be measured not at the tip, not down, but measured 1 to 3 centimeters where the point where the IVC joins the right atrium. Another thing important is to measure the right ventricle in the particular type of cardiac of the respiratory phase. For example, you can just put M mode and you can see the phasic variation of the inferior vena cava up and down motion with the respiration. And this indicates this patient, you have some phasic variation, but the phasic variation is the tune of 40 to 50%. Now, a normal person will have a more than 50% collapse of the inferior vena cava on inspiration. One important caveat is that if you are called to ICU to see a patient and the patient is positive pressure ventilator, you have to remember this IVC is a little bit larger and really may not collapse. So once you determine the IVC size and you determine the phasic variation, you can use this to calculate the right atrial pressure by using this following method. For example, IVC size is more than 2.1 centimeter. That means this IVC is dilated, and this IVC is collapsed less than 50% with a sniff. This indicates the RA pressure is a little bit on the higher side, around 15 to 20 millimeters of mercury. And this value you have to add to the Bernoulli's equation to determine the right ventricular systolic pressure. For example, we have this patient where you can see that the interventricular septum is a little bit flat. There is actually moderate to severe tricuspid regurgitation, and the pulmonary pressure measured is 55 millimeters of mercury. Now we have to measure the RA pressure estimate. It is 50 millimeters of mercury, indicating total RV systolic pressures of 70 millimeters of mercury. So chairman is giving to the end, but I will just take 2 more minutes. One more thing to measure, apart from strain and straight imaging, is to assess the right ventricle by using 3D echocardiography. But I will not really bore you with this because 3D echocardiography assessment can be better done by the MRI than by echocardiography because the whole RV is not the common plane. I will just show you one case in the end, how to integrate everything in the practice. So this is a patient who has come to us with this. She's a 14 years old girl, and I was called at midnight because she came to us with shortness of breath for 2 days. And as you can see, there is a right ventricular dilatation and there is a tracheostomy moderate, and you can see that the RA is actually hugely dilated for her. And as you can also see, she is only 14 years, but actually the right ventricle is dilated and the septal motion is D-shaped. Then you can see, you look carefully, actually you can see there is a clot in the pulmonary arteries for him, and this is a longitudinal strain. You can see it is actually reduced. It is not that much reduced, reasonable in spite of having RV dilatation, is minus 17%. So this is not really an RV which is a chronically dysfunction. This RV which is a normal RV was having an intense hemodynamic stress. So at midnight, we thought about diagnosis of pulmonary embolism, and obviously the patient went for CT scan, and as you can see, there are bilateral saddle-shaped pulmonary embolism in the practice. But we were trying to look for the source for pulmonary embolism, why she had. So I asked the radiologist to actually do a CT scan, and the CT scan went down. You were surprised to see actually she is pregnant 3 months. So she is a 14-year-old girl who was pregnant 3 months. She was immobile, and she developed massive pulmonary embolism in the night. Came to us something like 2 o'clock in the morning, and we did a workup. We find protein C and was low on the lower side, but antithrombin 3 and factor Leiden was negative. She was put on low molecular heparin, and she had an uncomplicated delivery, and she came few days back to see me with her baby. So she's doing well actually in the clinical practice. And last case I will show you
I think
is, you can see, before I close, you can see actually a big clot in the right ventricle with the dilatation of the right ventricular cavity. And you can see the longitudinal stroke of the left ventricle is normal, but the right ventricle is severely affected, is minus 9.8%. The conclusion by the talk that recent developments in the echo techniques enable us to assess the right ventricular size and function more accurately. Not only one can assess that by using M mode, but we can use, for example, TAPSE, SWAVE, and advanced techniques like longitudinal strain to assess the right ventricle. The whole key is to have a high frame rate, and as the machines are getting more evolved, the frame rate of the machine is improving. Like 10 years back, we 10 to 12. Now it's very common to use frame rate 30 to 40. It is possible sometime down the line, the whole 3D echocardiography of the LV and RV can be done by a single frame. Thank you very much.
Thank you, Dr. Alvarez. Excellent talk on how to assess RV functions. So our next speaker will be Dr. Hussam Zaki. He's a consultant cardiologist, Dubai Hospital. He'll talk on current role of echocardiography in assessing viability. Welcome.
Thank you. Well, I would like to thank the organizing committee for inviting me. We will try to have an overview about the current role of echo in this, assessing myocardial viability. Viable myocardial segments characterized by reduced function at rest, but potentially recoverable either spontaneously in the stunned myocardium or after revascularization with hibernation. So what is stunning? Stunning is a persistent contractile dysfunction with delayed recovery after transient ischemia despite adequate perfusion. And it is a prolonged functional depression requiring more than 24 hours for recovery, and develops on reperfusion even after brief periods of coronary occlusion, which are insufficient to cause necrosis. Likely causes are cellular calcium overload, free radical generation, and neutrophil accumulation. And it is seen during reperfusion status, post-myocardial infarction, unstable acute coronary syndromes, and exercise-induced ischemia. Hibernation is the chronic depression of myocardial function, which exhibits complete or partial recovery of function after revascularization. It is associated with severe coronary artery disease and originally thought to be due to decreased myocardial blood flow. Now realized to be multifactorial due to repeated ischemia in collateral dependent myocardium, decreased coronary perfusion in post-stenotic bed, and ischemia-induced changes in gene expression, the preconditioning. In contrast to stunning, it is associated with loss of contractile material and severely decreased residual coronary flow reserve, effective ability to respond to inotropic stimulus. It is an unstable state, not the successful adaptation to ischemia once we thought. Stunning and hibernation frequently coexist and contribute to congestive heart failure. It was initially described by Nesto et al. So what are the methods? I think over the day you have gone through MRI and CT and all methods. So the methods to detect viability are the positron emission tomography using metabolic imaging like fluorodeoxyglucose, or positron emission with the dyes, or myocardial contrast echo, cellular membrane integrity in the SPECT technetium 99 or thallium 201, or contractile reserve using echocardiography, or the gold standard of viability now is the cardiac CMR with low dose or dobutamine CMR. So what is the resting echo would show us as a clue for viability? The echocardiographic parameters at rest is important in the assessment of viability. Severe dilatation of the LV is a marker of non-viable myocardium with higher end systolic volume indices associated with poor ventricular functional recovery, especially if the end systolic volume exceeds 130 ml. We can see from this study in the Journal of Thoracic and Cardiovascular Surgery that the more the end systolic volume increase, the more the relative risk and event rate increase. And that curve starts to rise from 130 onwards. The second clue in echo, or the resting echo or transthoracic echo for viability, is the wall thickness, less than 6 millimeters. It is a sign of loss of viability. So when you do the transthoracic echo, you have to judge this myocardium is viable or non-viable. When it is viable, the thickness definitely should be more than 6 millimeters. If it is suspected to be a scar, it will be thinned and it will be echo-dense. Echo-dense means hyper-reflective. The second and important technique in examining viability by echocardiography is dobutamine echo or dobutamine stress echo. In the dobutamine stress echo to assess myocardial variability, you get improved contractility of dysfunctioning myocardium under dobutamine infusion, either early after MI, the stunned myocardium, or the chronic LV dysfunction, the hibernating. This takes time to improve, and this needs revascularization like CABG or PCI to predict the recovery of LV function afterwards, whether time or intervention. If we look to this diagram, it summarizes how we judge the response to dobutamine by echo and how we diagnose stunned, hibernating, or a scar. At rest, when you have depressed contractility, if it improves by dobutamine, if it doesn't improve at low dose and then doesn't improve on high dose, you are dealing with a myocardial scar. If it is depressed at rest and at low dose improves and at high dose still getting more improvement, you're talking about a stunned. That's the stunned means it is perfused, but it takes time to recover. And the last but not least, if you have a depressed myocardium that improves with dobutamine initially and then get worsened, the so-called biphasic response, it is the most specific response to viability and denotes that this myocardium is viable, and if you revascularize it, it will improve. The biphasic wall motion response at low dose, hibernating myocardium will augment due to inotropic stimulation, and at high doses, hibernating segment may exhibit abnormal wall motion. This biphasic response appears to be the most predictive of post-revascularization viability, and in the guidelines of the American Society of Echocardiography, it recommends that viability assessment includes improvement in at least 2 echocardiographic left ventricular segments. We know that in echocardiography, most of the time we divide the ventricle into 16 segments. So if you get improvement in 2 out of 16, this myocardium is viable. This patient should be revascularized. Here's an example how of the response when you have a stunned myocardium. When the endocardium is depressed, then at low dose and high dose, it improves and sustains a little bit in the recovery. That's another example of a normal stress echocardiography at a heart rate of less than 50 and then at a heart rate of 100. And it shows that there is no regional motion and all the segments are thickening both in 4-chamber and 2-chamber views. So what exactly happens when you stress a patient? We all know the ischemic cascade. When there is induction of ischemia or decrease perfusion, there is first the perfusion heterogeneity, and then the metabolic alteration, then the diastolic dysfunction, then the regional dyssynchrony, and here the echo will be positive for regional motion abnormalities. Then the ECG changes would appear, and finally the patient will get chest pain, and if you go on more, you might induce necrosis. So here we have to compare between different type of responses. When you talk about wall motion, that is advanced in pathology here, sorry. Wall motion is like before the last two steps. And when you talk about perfusion, it is in the beginning. So when you talk about inducing new wall motion abnormalities, that is more specific. And this is what hits the decision. Is he going to improve? Is it worth it to do CABG? Because CABG is a major operation. When you talk about perfusion changes, it is more sensitive. It appears early, but less specific and may occur without producing ischemia, and that is the issue. Here also the same comparison, but not by perfusion heterogeneity and regional motion. It is between dobutamine that induces regional motion and pyrzintine or dipyridamole that induces the heterogeneity in the blood flow. And we can assure that dobutamine more towards myocardial dysfunction, more specific. So why echo? Echo, in comparison to Spectrum, PET, and others, it is low cost, environmental friendly. We have no radiation, non-ionizing radiations. It is equally accurate. So it's a test that can be done bedside. You can do it at any time. It's cost effective. It can be done even in secondary care. You don't need a fancy hospital to work. You can do it anywhere. So it is within hand. What is the evidence behind stress echo inviability, whether in chronic systolic dysfunction or in stunned post-myocardial infarction to predict recovery? Dobutamine stress echo in coronary artery disease and ischemic cardiomyopathy help to identify patients most likely to have improved survival. In ischemic cardiomyopathy, it identifies patients with the highest chances of survival post-procedure, and in chronic artery disease, it's useful in predicting ultimate post-revascularization left ventricular recovery. So what about post-MI? It has a sensitivity of 82% and a specificity of 80% in most of the studies for detecting residual stenoding, subtending an area of hibernating myocardium. Also, myocardial viability early after MI. Single best predictor of recurrent in-hospital ischemia and unstable angina after discharge. Also associated with better left ventricular function recovery and lower long-term mortality. So it can help you in deciding what to do with the patient. Also, another evidence for the post-MI dobutamine stress echo in the myocardial viability assessed by dobutamine stress echo predicts reduced mortality early after acute myocardial infarction, determining the risk of events after myocardial infarction, the DREAM study. In this study, the conclusion was this study adds to the available data showing that dopamine stress echo is a powerful predictor of outcome of stable survivor of acute MI and provides evidence that the presence of myocardial viability detected by dopamine stress echo has a positive impact on survival. So post-MI can help you to predict the recovery, whether to revascularize or not. But the big blow was the STITCH trial. What happened in the STITCH trial? That STITCH trial, they recruited 1,200 patients going either for intensive medical therapy or for coronary artery bypass-grafting. Those patients were, half of them underwent a viability study, and this is the sub-viability study of the STITCH. In this viability study, or the crucial point was those viable patients who were judged to have a viable myocardium. Some of them underwent CABG, and others were subjected to only intensive medical therapy. And what happened is they found no difference. And upon this analysis, most of the authorities said, okay, so viability is not worth it, so we should not do viability for patients who are having multi-vessel disease and chronic systolic dysfunction. Those patients should have because viability doesn't change. Well, we will go in summary about the trial, and we will go through the criticism about this trial. So in conclusion, having retained myocardial viability, they got better results. This is in total. And they have better mortality, and those who have no viable myocardium, they had a worse mortality. And half of the patients had viability studies. 114 was judged to be non-viable, and 487 were judged to be viable. Half of them had CABG, and the other half had only intensive medical therapy. And when those groups were compared, there was no significance between the two groups, whether the age, the gender, the previous MI, multivessel, proximal LED, all this. But when they did the analysis of the group who had CABG versus medical treatment, the viable myocardium, there was no significant difference. Means testing viability or operating on viable people, whether operating or intensive medical therapy, no difference. And this created a lot of chaos. And actually, for some centers, they stopped doing viability tests. And their limitation was lack of viability data in all patients because there were 1,200 patients. And this was a post-hoc analysis. It was not put as a primary endpoint. Also, analysis limited to SPECT and dobutamine echo, no PET, no MRI in those cases. The STITCH represents the largest report to date relating myocardial viability to clinical outcome of patients with coronary artery disease and LV dysfunction, and is the first to assess these relationships prospectively among patients who were all eligible for CABG, as well as optimal medical management alone. Also, it demonstrates a significant association between myocardial viability and outcome because those with viability did better. But this association is rendered non-significant when subjected to multivariable analysis that includes other prognostic variables and fails to demonstrate a significant interaction between myocardial viability and medical versus surgical treatment with respect to mortality, whether assessed according to treatment assigned, intention to treat, or to the treatment actually received. And in their conclusion, in patients with coronary artery disease and LV dysfunction, assessment of myocardial viability does not identify patients who will have the greatest survival benefit from adding CABG to aggressive medical therapy. But other authorities started to analyze this paper because it was detrimental, so people should have a view about it. Analysis of a randomized trial based on variables not included in the original randomization process introduces a clinical bias and weakens the results. This was not an end result. This is just a subgroup of the STITCH. They had the viability, and they used two tests, not one test, with different techniques, and they grouped them together, both of them together as viable or non-viable, simplifying the issue and without unifying the techniques. Only 267 patients of the 1,000 undergoing surgery in the STITCH had viability data. Nonetheless, it is intuitive that CABG alone would yield significant benefit in patients with septal and apical viability, and that addition of surgical volume restoration might be harmful in these patients because in the STITCH there was surgical volume restoration. Conversely, CABG plus SVR might selectively benefit those with non-viable myocardium to be excluded by SVR. They excluded patients with left main disease, severe or unstable angina, and acute coronary syndrome. Also excluded patients with apical aneurysm and no need for surgical coronary intervention.
We have only 3 minutes more.
Oh, okay. So I'll get to the last message. The assessment of myocardial viability in the selection of patients for myocardial revascularization has suffered a significant blow with the results of the STITCH trial. And these results certainly represented a wake-up call for the cardiology community. However, when put in this perspective and properly dissected, the STITCH trial should be seen not as a definitive and final answer to the question of viability assessment, but rather as a matter of reflection, particularly in the following two aspects: proper patient selection and proper methods and criteria of assessment of viability. Thank you.
Thank you, Dr. Hussam, for the nice talk on viability. Our next speaker is Dr. Vimal Raj, consultant cardiologist, radiologist, and head of radiology. He will talk on cardiac MRI, the gold standard for ischemic heart disease. Welcome, Mr.
Thank you. Okay, we are getting a little thinned out in the audience here. That's good. Okay. No, I don't need. Thank you. Okay. Going to talk to you about cardiac MR, gold standard in ischemic heart disease. some of the basics have already been covered, so that's very good. So we'll be able to run through this. Just a little bit of show of a hand. You cardiologist, sir? Perfect. What about you three guys? Techs? Medicine? Perfect. I know who you are. I know Amit. I know you, sir. You're also, I know. So there's a radiologist there. So I kind of know who I'm dealing with. Perfect. So gold standard test for assessing ischemic heart disease. What is gold standard? Well, gold standard is something which is accurate. The information it gives is always kind of the best, and nothing else compares to it, and it does all the things which is great. Now, we're going to talk quickly about what do we need in a test in a patient with ischemic heart disease. I'll compare cardiac MR with SPECT and PET and some sample cases. Well, as a clinician, as a cardiologist, what do you actually want from a patient is sitting in front of you and you are worried about ischemic heart disease? First of all, you want to say, is there ischemia in this patient? That's number one. If there is ischemia, which vascular territory is it? Is it LAD, RCA, circumflex, 1, 2, or triple vessel? If there is coronary artery disease, is the myocardium viable or not? And if it is viable, what is the LV function? Based on all this data, you would go and manage the patient. Now, if any of these answers are not correct, and then you realize, hey, if this is not ischemic heart disease, what is it? So if patient comes with chest pain, but your coronary artery disease is not there, then what is it? So that's all the questions that one needs to answer. Now, as we just saw earlier, the ischemic cascade, one of the things which we are able to pick up very, very early is perfusion abnormality. Before patient presents with angina or even ST changes, what we are able to see is perfusion abnormality. And this is what we try and depict in cardiac MR. With the first pass perfusion, we use vasodilator stress using adenosine. Dobutamine can also be adenosine. So what happens here? Okay, as part of cardiac MR, we stress the patient with adenosine for 3 minutes. And at the end of 3 minutes, we give them contrast and we see the contrast run through the myocardium. What you're going to see here at the top, these are short axis images at stress, where the patient is at peak stress. And at the bottom are 3 images at rest. Try and concentrate on the images at the top. What you're looking for are areas of darkness in the myocardium, which tend to stay a little bit longer compared to the other areas. So when we look at here, we're somehow in this area, the inferior segments, if people can appreciate it. Can you see it, sir? Do you think you can see it? Yeah. Okay, some heads nodding there. And at rest, that area actually is not hypoperfused. So at stress, that area is hyperperfused, and at rest, it is normal perfusion. So this is something called as a stress-induced reversible perfusion defect. So there is a perfusion defect at stress, but nothing at rest. Now, static images of a different patient. At stress, you can see these 2 sections. At stress, very nice hypoperfusion in the subendocardium along the septum and the anterior segments, while at rest you do not see this. So this is stress-induced perfusion defect with MR having great spatial resolution and contrast resolution that we can see. So first question, is there ischemia? Cardiac MR can answer you that. That's number 1. Which vascular territory is involved? It's very simple in terms of the way we look at the distribution. This is the standard areas of LAD, the yellow ones, the basal anteroseptal and anterior segments going into the apical septum and the apical anterior segment and apex. If right coronary artery is the dominant vessel, then this all red area is supplied by the right coronary artery. So we are talking about infroseptal, inferior segments. And the circumflex tends to cover over the lateral wall. Now, if the left circumflex is dominant, then maybe the apical inferior segment or even the mid-inferior segment may be supplied by the circumflex. So this is not very clear cut. It changes with the coronary anatomy. When you have LAD, which is type 2 RCA may be supplying more areas. These will help you in deciding which vascular territory it is. The second question comes is which coronary artery, as we said. Now, cardiac MR is making big strides in actually assessing coronary arteries. We are not there yet. So this is cardiac MR images, non-contrast cardiac MR images, and where you can see this is an anomalous left mainstem arising from the left coronary cusp. This is the RCA, and this is a malignant coronary anatomy of aorta, pulmonary artery, and the coronary artery running across. You can see the RCA very nicely in this case. This is free breathing, patient lying down, and we don't give any contrast, and we can see these coronaries. In an acute MI setting, cardiac MR gives you much more information because it gives you areas which are similar to this, which we call, if you remember, I was showing you earlier, anything white on delayed enhancement imaging is not good. This is all areas of dead myocardium. Within that, you're getting spots of blackish myocardium, which are areas of microvascular obstruction. Microvascular obstructions or no reflow phenomenon areas are very, very bad for prognosis. You can also see nice clots in patients who present with acute MI. So, when you compare the evidence of cardiac MR first pass perfusion with SPECT CT, with MR impact trials or the CE Mark study, what you will see that patients who have got a normal stress MR do extremely well. They do not have any major advanced cardiac events. They do not have cardiac complications, while compared to SPECT, it's very, very superior. I'll show you an image a little bit later about that. So we've decided that, yes, there is ischemia. We've also figured out which vascular territory it is. The next question comes is, should I actually revascularize it? Is it viable? Now, viability assessment, we just heard about the STITCH trial. It's one of the big bugbearers in our studies where we do not like the findings of the STITCH trial. But just before that, if you look at a lot of evidence which clearly states that people who have viable myocardium, they do better by revascularization. And more importantly, if the myocardium is non-viable and you go ahead and revascularize, they do very poorly. So how do we assess viability in cardiac? We look at three things. We look at wall thickening, we can use low-dose dobutamine, and we use delayed enhancement imaging. Now, wall thickening is one of the thumb rules. You can say that anything which is thicker than 6 millimeters end diastolic wall thickness of more than 6 millimeters is most likely viable. Okay, it's most likely viable. I wouldn't say 100%. We are looking at a specificity of around 90 to 95%. Because with myocardial infarction, the myocardium gets thinned out. Now, if you look dobutamine, what we just heard earlier, cardiac MR, also we can do dobutamine. You can look in this segment, the inferior part of the wall is not moving that well at rest. We give low-dose dobutamine, and you can see that the whole inferior part gets much better in contraction. It gets much thicker, saying that, yes, this is viable myocardium and will improve with revascularization. The most important part of delayed enhancement imaging in viability assessment is this, which we talk about the amount of infarction. So if you imagine there are 100 layers of myocardium, and within the 100 layers, if more than 50% of the myocardium is dead, which basically means more than 50% is bright, it is non-viable. So if you see in this, this is the anterior wall. Almost entirely the anterior wall is gone. It is dead. Now, if you see here, the white one is dead while the black one is viable. Okay, so this is about 50% of the myocardium is dead, or 50% subendocardial infarction, making this likely to be a viable segment. There is good evidence to support this. So anything which has more than 50% of subendocardial infarction is non-viable. Now let's look at this. Some of you, let's see. In this case, this is a separate case on the left-hand side where you can see this whole area is enhancing. Which vascular territory is this, guys? Yasmin is not allowed to answer. Which vascular territory is this, guys? Most probably circ. If it's a left dominant, this is a right dominant system. So this would be RCA. Okay. Do we think this is viable, non-viable? How many of you think it's non-viable? Remember, I was telling you if it has got 100% of infarction through and through, or anything more than 50% of infarction, it's likely to be non-viable. How many of you think it's non-viable? Okay, good enough number of hands. Excellent. Now let's look at this. This is a different patient now. And how many of you think this area is viable? Okay, quite a good number. Again, this is less than 50% infarction. Yes, less than 50% infarction. This is the lateral wall. This is likely to be the circumflex territory in this case. So this is viable myocardium. Looking at the delayed enhancement in isolation or dobutamine in isolation, when we look at everything together, what happens is that our specificity and sensitivity significantly improves. So in real life, this is what happens. Okay, in real life, this is what happens. We assessment for this. So if you see in this image, just stop playing. Yeah, this image, this myocardium is thinned out. It is not contracting. It is actually going out. Compared to this myocardium, you can see here, it's nicely contracting. This is going out. And this patient, again, this whole area is got full transmural enhancement, suggestive of infarction, and that it is non-viable. Okay, so we've answered, is there ischemia by stress testing? We've answered which vascular territory is it? Then we say, is it viable? Yep, it is viable. Then you turn around and say, what is the LV function? Let's say it's non-viable. There is no ischemia. It's all dead. What is the LV function? We do know that cardiac MR is currently the gold standard for LV functional assessment. Okay, it is the gold standard. It is reproducible. It is got the least variability amongst inter-observer and intra-observer. Okay, and when we give these functions, you can decide on whether this needs a CRT, okay, aggressive medical management, or you're going to put a device in this patient. All that based on this. Now, let's say this is one patient who came in with chest pain, but the coronary arteries were normal. Patient came in with chest pain, trop I was high, but the coronary arteries were normal. Now, you get stuck with these patients. So you do cardiac MR in these patients. What you see here, there is a small pericardial effusion, not much. This is edema imaging. And you can see this is normal myocardial signal here. And just this one spot, there is a little brightness. And the same thing in here on delayed enhancement imaging, there is focal mid-myocardial and some epicardial enhancement. This is acute myopericarditis. So the patient came in 6 months later, the same patient, you can see the area of edema is gone. The area of enhancement has also shrunk down significantly. So if a patient comes in with suspected ischemic heart disease but does not have ischemic heart disease, cardiac MR will tell you what it is as well. So it's not that always when you have two different patients, okay, two different patients, which is kind of what we see more often nowadays, is that both have come with heart failure. Both have come with poor LV function, okay? And this is what echo would do, okay? Echo will give you this and say that, hey, LV looks dilated. In this case, it looks globally not working well. In this case, perhaps you may appreciate that this area is not working as well as the other. Now, delayed enhancement clearly tells us now that this whole myocardium is dead here. You can see this is all enhancement. This is an RCA territory infarct, while this one has got a mid-myocardial enhancement, which is a very well recognized phenomena in idiopathic dilated cardiomyopathies. So you could have patients, young patients. So in our center, what we've done now is young patients who come in with dilated cardiomyopathies. When we say young, anybody under the age of 40 with dilated cardiomyopathy, we do stress MR for them. So we exclude ischemia. We tell them if there is any viability issues, if there's any infarction, or what is the cause for their dilated cardiomyopathy. Let's look at 2 cases and then we'll finish. 45-year-old male who came in with recent myocardial infarction. Echo showed LV dysfunction and regional wall motion abnormality. Coronary angiogram had shown LAD and RCA had more than 90% disease. Okay, so we were not interested in ischemia assessment. We wanted to make sure that these 2 territories are viable for us to go and do any revascularization. And we've done, let's look at simple things which are easier to pick up. Right ventricle is functioning well, non-dilated. Okay, this is the left ventricle. You can see all these areas are functioning well. Something is going on towards the apex. You can see every time the apex is just not moving as well as what you would like to see. Anybody appreciate any small spot in here? Can everyone see this small black spot in the LV apex? So that's likely to be a clot. So we do delayed enhancement imaging. And on delayed enhancement imaging, you can see that there is a nice clot there. And at the apex, it's got a transmural infarction, i.e. more than 50% infarction. So apex is non-viable. Now let's look at this segments. Let's just concentrate on, let's just the apical septum. How many of you think this is a viable myocardium, apical septum, based on just delayed enhancement? Good, because it is less than 50% enhancement. So this is viable. So this patient would benefit from revascularization. Let's see another patient, 67-year-old male, chronic history, previously had an LAD territory infarction. LAD has got proximal disease. Echo showed LV dilatation. And again, the question was, is this territory viable or non-viable? So now when you start looking at this, let's look at the 2-chamber view across here. Anybody want to say anything? Thin myocardium, excellent. So you're seeing that down here is thinned out, extending into the inferior aspect, all along here as well, not contracting that very well. You do delayed enhancement imaging, and you can see all of this is dead. This is all dead. Up till this point, there is some viable myocardium at that level also. So this is subendocardial infarct, and this is transmural infarction. So basically means this patient is for medical management, i.e. these segments are non-viable. Anything else you can offer him surgically? Any surgeons amongst us left? Sir, anything? So we've started, if you heard the stitch trial, so one of the things which goes very well is surgical ventricular reconstructions or DOS procedure. So whereby you get rid of this dead myocardium and you stitch the viable to the viable tissue, and then the LV function improves significantly. So we do lots of DORS because in the Indian population, infarcts, patients present very late in their life. They're chronic infarcts where the LV has badly remodeled into this. Interesting case, 50-year-old male had an infralateral infarction, which we could see on an echo, regional wall motion abnormality, but he presented with ventricular fibrillation. He presented bad, and poor LV function was not good. So we did this. You can see short axis images, and you can see this. This is a pericardial effusion around the patient's heart. Any part of the heart which is not moving? The bottom bit, the inferior one, you can see here, not moving. Echo would have shown you that. CT, if you do dynamic, you may see that. What MR does shows you this. Now, if you remember, I was telling you all white is bad. So this is all white, black island of tissues. These are areas of microvascular obstruction, and these do extremely badly. That's why the patient presents with VF. So once you know this, you aggressively manage this patient, and they get treated in a totally different manner. So why CMR? Well, All of these things, LV ejection fraction, the end diastolic volume, microvascular obstructions, all of them are independent predictors of prognosis. And all of these can be derived with cardiac MR. Secondary features, if you want to go and do an LAD repair, you want to do a bypass, you want to know, do I need to fix the mitral valve or not? You could do that. You can see in this case, the severe amount of mitral disease. You can see the mitral regurgitation going all the way up. And when you have aneurysms, this is when other modalities start struggling. You can see that this is huge aneurysm post-infarction, and reconstruction of this is very easy with the help of cardiac MR. Comparing it with SPECT is very, very, I think it's not a competition at all, because cardiac SPECT has got a very poor spatial resolution. This is a very well published study. This is an animal model whereby artificially induced infarction. The coronary arteries got tied off and there was infarction. You could see cardiac MR picks up subendocardial infarcts, which were present in the pathological samples, but SPECT does not pick them up because it does not have the resolution of doing this. So SPECT, I would just not even consider it as a competition for cardiac MR, whether you look at perfusion. PET is good. PET is decent, especially if you're looking for viability assessment. PET does a good job, but radiation is a problem. You may not have a PET available as easily as what you will have in cardiac MR. And PET will not give you any other extra information that we've been talking about. So the take-home message is that cardiac MR is a one-stop shop. One test, everything about ischemic heart disease gets dealt with on one occasion itself. Ischemia, viability, vascular territory. If not ischemic heart disease, what is the condition? All of that gets answered in one. Prognostic information is easily available. Coronary artery status, as in you may have, let's say somebody comes in with chest pain and you choose to do a functional assessment. Let's say it's a 60-year-old male, medium risk for coronary artery disease. You choose to do functional assessment and you say there is no inducible ischemia. It actually does not answer your question of, does he have coronary artery disease? Okay, he may have subclinical coronary artery disease. So combining that with calcium score is a new way of dealing with it. Do a perfusion cardiac MR. If normal, do a coronary calcium score. But future, it may be much bad. So it is the gold standard of ischemic heart disease assessment. I would not necessarily recommend that as a first step for everybody, but it has its role in a lot of patients and will do a great job. Thank you very much for listening.
Thank you, Dr. Bimal. Our next speaker is Yasmin Hanif. She'll talk on CMR in non-ischemic cardiomyopathies.
Welcome back. So we're going to carry on again cardiac MRI, and in this case, we're going to talk about cardiac MRI in non-ischemic cardiomyopathy, and this is quite long category. And from our previous talk, I was about to talk about ARVC, so we'll carry on with the ARVC as a cardiomyopathy and carry on with the presentation in here. Carry this one. So, okay, here we are. So, ARVC, arrhythmogenic right ventricular cardiomyopathy, is a serious diagnosis, and we all know that it's associated with a sudden cardiac death. It's the second cause, actually, after the coronary artery anomalies, is the ARVC. The presentation for the patient mostly with the ventricular fibrillation, and we see those patients actually without previous history. So we started research to understand arrhythmogenic cardiomyopathy, and with the genetic testing, actually, our understanding of ARVC has been completely different. So in 2010, the task force criteria has been changed, and we used to have a qualitative assessment of the regional wall motion abnormality in terms of imaging, but with MRI and echo now, we have a quantitative assessment, which is in term is the end diastolic volume of the right ventricle and also the RVOT measurement. Then the criteria has been modified. And if we go quickly through that, the 2010 revised task force criteria, it is 6 category, and 3 of them are with the ECG finding, and 1 of them is with the imaging, which is global or regional dysfunction found, and then the invasive one with the endomyocardial biopsy, and the 6th one is a family history. So what we are going to discuss here, that in imaging term, we use 2D echo, and we use CMR. CMR and 2D echoes, for the patient to get the diagnosis of ARVC, you have to be specific, because nowadays it's overdiagnosis. Patient get ICD for a wrong diagnosis. So what we do in CMR, as I've previously explained, ARVC, you have to go to transaxial and assess the regional wall motion abnormality. And it has to be dyskinesia or desynchronous RV contraction. This is one of the major criteria. In addition to that, with the revised criteria, I will add the diastolic volume, and I have a cutoff more than 100 ml for male, and it's 100 for female. This is very specific, and it gets much better with the ejection fraction assessment. So either less than 40% is a major criteria, or 40 to 45% as a quantitative assessment for the right ventricular ejection fraction. Again, the RV angiography has been there before cardiac MRI. Then in echocardiography, the RVOT diameter, also one of the quantitative assessment for ARVC. And then I have explained that the endomyocardial biopsy, but we would not reach to this before the other criteria. Repolarization abnormalities. We have to look at a T-wave inversion. And nowadays, that the electrocardiogram is the first presentation of first abnormalities for those patients, not imaging, not family history, ECG. So ECG, T-wave inversion, epsilon criteria, I believe that you know that. And if you have non-sustainability of the left bundle branch block morphology, and whether with superior axis or different axis. And then we go further with the family history, a sudden cardiac death. If anybody has been established with this diagnosis, then we run a screen of that. And what we see in MRI, we've been doing, in my center actually, we've been doing a lot of research, genetic research, and imaging along for those patients. So what we see in CMR, actually, we used to believe that ARVC is an endomyocardial abnormality in imaging, that we see that some abnormality in the endomyocardium. Actually, it's not. Actually, it's an epicardial disease. EPS study has proved that. And other thing, that the subtricuspid area is the most common area that has been involved with the right ventricular dyskinesia or dysynchronous contraction instead of the apex has been used to describe. So this is the 4-chamber view, tricuspid valve, the right ventricle, and this is in diastole. Diastole here, and then in systole, this is a bulge. It has been there. This is abnormal. It has to be homogeneous, synchronized, and this is what we call subtricuspid area. This is the tricuspid valve, and this is the area. Most commonly, you see the regional dyskinesia in this area. So, next. This is new. Left ventricular involvement. With, as I said, early genetic testing, patient referred to us with positive family history, and we do cardiac MRI. What happened? Right ventricle normal, ejection fraction is normal, there is no regional wall motion, akinesia, but we found fibrosis. So what's going on? Now, we discovered that the left ventricle can be affected as an early sign of ARVC. And most of the time, they become a predominant left ventricular involvement. So it's a biventricular disease with a right case. Patient referred to us, family screening of ARVC. He has a brother diagnosed with this disease. And when we did an ECG, we have a T-wave inversion in lateral leads. As I said, ECG was positive family history. We did MRI. The echocardiography has to go with MRI. We don't do MRI alone for the RVC assessment. So it was normal, completely normal. And when we did it, the MRI, it was also completely normal. Normal RV function, normal LV function. There is no dyskinesia anywhere in the right ventricle either, with normal ejection fraction. But we found diffuse fibrosis here in the anterior inferior wall, and circumferential in here, in the left ventricle. So what is the diagnosis in here? Is it myocarditis with this history? Yes, it's not myocarditis. It's mid-wall, I do believe. ECG T-wave. This patient might have positive troponin, but even if he has a positive troponin, this is not myocarditis. This is, sorry? Yeah, with the fibrosis in the left ventricle, but with this family history, do you think that this is a myocarditis? No, yes, so it's a left ventricular, arrhythmogenic left ventricular cardiomyopathy. So you got to be careful when you put the diagnosis with the mid-wall fibrosis with the left ventricle. Going back to the history, this couldn't be a myocarditis. We have another case actually presented with syncope, ECG with T-wave inversion, the same scenario, troponin was positive. And we did a cardiac cath actually, and it was normal. He was young, there is no family history. And we did a cardiac MRI, normal RV, normal LV. And there is a mid-wall fibrosis. They just concluded it's myocarditis because the patient has a positive troponin. Actually, history of syncope, yes, it's arrhythmogenic left ventricular cardiomyopathy. It could be in a further down in history that would affect the right ventricle, but right now it's a left ventricular involvement. It could be predominant to the left ventricle, but does not exclude the right ventricle. We did to this patient with positive troponin, we asked to run a genetic test. This is my message, actually, that's why I put the presentation. So, what do you want to take home message? Now, the definition of ARVC is intramyocardial fat accumulation. In imaging, we don't take this definition into account. It's not reproducible to look for this sign, actually. What's also to be mentioned that the late Gadden has been described as a sign of right ventricular ARVC involvement, but in the task force criteria, this has been taken. It is recognized, but it's not been taken because, again, the right ventricle in this pathology itself is thinned out. And even if you have experience, CMR reader, they will not agree in the right ventricular fibrosis and late Gadden enhancement. So we don't consider late Gadden enhancement as a major task force criteria or as a diagnostic for ARVC. The common finding of the ARVC is the subtricuspid region, as I said, and don't forget the left ventricular involvement. It could be predominant or an early finding of ARVC. And revised task force criteria does not exclude echocardiography and you have to take into account the electrocardiogram. As I said, it's an early abnormality could be presenting in ARVC. So I will move to the next pathologies. So non-ischemic cardiomyopathy again. My colleague has explained very well that the late GAD enhancement with the ischemic cardiomyopathy, and I'm not going to repeat that, but actually what we asked to do with dilated cardiomyopathy, hypertrophic cardiomyopathy, left ventricular non-compaction, and cardiac amyloidosis, all those pathologies are going to be recognized by the pattern of the late GAD enhancement. Just knowing the fact that gadolinium does not stay in the intracellular space. It's an extracellular material. So any living cell does not take up gadolinium. So when you see gadolinium, so it's not a viable cell that can take gadolinium. This is by definition. So when I do cardiac MRI for those categories, so I have to look for the pattern of late GAD enhancement. But again, I have to be careful with the assessment. In dilated cardiomyopathy, my colleague explained that you could have with mid-wall fibrosis, subendocardial involvement is not going to be the dilated cardiomyopathy diagnosis. This is absolutely true. But apart from that, in dilated cardiomyopathy, I will look for the right and left ventricular assessment. And beyond that, the presence of mid-wall fibrosis is an indicator of a poor prognosis in the recent trial. So I will get mid-wall fibrosis, and I will expect that this patient has a poor outcome after the cardiac MRI. Then what I recommend actually, patient with dilated cardiomyopathy, poor ejection fraction, what are you going to do? In our population, it might be what? Is it idiopathic? No. You have to take into account that sometimes patients with ischemic cardiomyopathy, they don't have an infarction, so they don't have late GAD enhancement. So it's in a gray area, which is a stunning or hibernating myocardium. So you have to rule out ischemia by definition, even when you have no GAD, or even mid-wall and fibrosis. Sometimes in cases you get surprised. So rule out myocardial ischemia. If you can do cardiac cath, this is quite fast. If you can do stress MRI, this is much better. So stunning myocardium and dilated cardiomyopathy can be misdiagnosed. What we see actually dilated heart, and we could exclude other pathology like AR or MR as a cause of dilated cardiomyopathy. And the silent killer is the hypertension, advanced hypertension. We can rule out also by cardiac MRI this disease. As I said, the pattern of late different pathology like amyloidosis, sarcoidosis, it can be anything. It can be endocardial, not endocardial, so it can be epicardial, mid-wall, can be patchy, different pattern. Myocarditis, the same. But the ischemic cardiomyopathy, coronary artery-related endomyocardial enhancement. That's the late GAD enhancement, just in quick term. Then I'm going to talk about hypertrophic cardiomyopathy. We know hypertrophic cardiomyopathy is also an inherited cardiac disease with a poor prognosis in early age of diagnosis. Well, elderly with hypertrophic cardiomyopathy do much better. So what is the role of MRI? We can establish this diagnosis by echo. You can see LVH, but what after that? MRI, again, late GAD enhancement, can give you an answer. In hypertensive cardiac heart disease, you don't have fibrosis in the hypertrophied segment. So this is pathognomic. It could be hypertension. Sometimes patients present with both hypertension and hypertrophic cardiomyopathy. But if you find a hypertrophied segment with fibrosis, mid-wall fibrosis, this is hypertrophic cardiomyopathy. And what we use MRI also to help with the risk stratification of severe HCM, whether we need an ICD implant. But you could say that echo also can do that. But what about the apical HCM? Apical HCM is poorly seen by echocardiography. By ECG, you can find T-wave inversion, but echo cannot see the apical HCM. So it's better if you have a high index of suspicion, LVH, but it's clear, but ECG with T-wave inversion, refer patient for cardiac MRI. He might have apical HCM. This is the case I'm trying to, yeah, here we are. So this is the apex, and this is the late GAD enhancement with mid-wall fibrosis. As I said, this patient was referred only for the ECG finding normal echo. Actually, this is a study I just want to highlight quickly. The HCMR study in the UK started in Oxford University, and I was part of that. Actually, as we established that the late GAD enhancement in dilated cardiomyopathy can be related to a poor prognosis, this is what we're trying to do with a hypertrophic cardiomyopathy. So we're trying to establish whether the late GAD enhancement has a poor prognostic value for those patients, along with the T1 mapping, but I didn't want to go to the detail. And then this is stress MRI. The other category is cardiac amyloidosis. I think that you're familiar with this disease. It's a deposition disease, infiltrative cardiomyopathy. And nowadays, the endomyocardial biopsy is the gold standard for diagnosis, but with the help of cardiac MRI, it's a non-invasive test to do that. And guess or not, that with high positive predictive value and high negative predictive value, as a non-invasive test, replacing the endomyocardial biopsy, doing a cardiac MRI for those patients is really, really valuable. So what we find, again, LVH, and abnormal late GAD enhancement. It is diffuse, as I said, and sometimes in specific cases, you could have abnormal gadolinium kinetic, when the blood's supposed to be bright, but it's going to be dark pool blood. So this is a case. We do have contraction, but it's not really good function of the left and right ventricle. If we measure this, well, it is hypertrophied. So again here, so what is it? Biventricular dysfunction with diffuse LVH, some pericardial effusion. You have to pick up something in your mind when you see that in echo, and you think about what? Amyloidosis. So refer patient to MRI, and you get the late GAD enhancement. This is again the same thing, diffuse. What the point is? So diffuse septal hypertrophy and small pericardial effusion. Here, it's diffused. It's not, it's patchy and diffuse. So for this case is what? Amyloidosis, okay? This is a short axis view. And this is actually a sequence when the patient is really in heart failure and he cannot hold his breath. So we run a non-breath holding sequences. And as I said, one single shot here and you get the diffuse late GAD enhancement with the other features, so you get the diagnosis without going to an invasive test. Next is sarcoidosis, the same scenario of amyloidosis is an infiltrative disease. and actually it carry very, very poor prognosis when the cardiac involvement is there. So first presentation, usually they came with conduction abnormality and arrhythmias. And when the patient has sarcoidosis with this ECG abnormality, you have to refer for cardiac MRI. And in this area, actually, MRI and PET has really functioned together. We establish a diagnosis of sarcoidosis by cardiac MRI, and then we keep following up the patient with PET. I don't know, do you do, Ahmed, do you do PET scan in your center? Or no? Yes. It's a very rare, I mean, in Riyadh, we have only one center to do that. And, but we keep doing cardiac MRI as a follow-up. But actually in Brampton, we used to do as a primary modality. So this is a PET, and I will go through it quickly. And this is a pattern of the late GAD enhancement in cardiac sarcoidosis. As I said, this is diffuse, random, patchy, mid-wall, epicardial, the same as amyloidosis, but in addition, amyloidosis does have some abnormal in gadolinium kinetic. With cardiac sarcoidosis does not have this pathology. There is also the T1 mapping, but I don't want to go into these details. And last thing is compaction, and it is a form of cardiomyopathy, and that nowadays still echo is the first imaging modality for this pathology, but a group of physicians, they establish a criteria for cardiac MRI to diagnose left ventricular non-compaction. Well, you can see here that myocardium is quite thin here, and this is what we call the compacted layer, and here's the non-compacted layer. And the same thing in echocardiography. And actually, we do the same as echo, but as I said, MRI is superior to visualize the apex. So you have the choice to do it whether, but we do also the right and left ventricular assessment. So the take-home message that MRI is a superior diagnostic tool. If you have an ischemic dilated cardiomyopathy, if you have a dilated cardiomyopathy, you got to rule out ischemic cardiomyopathy and make sure that you're not missing hibernating or standing myocardium. In HCM, the presence of fibrosis at the hypertrophied segment make MR a superior modality to differentiate other causes of hypertension. And for amyloidosis, MRI is a superior non-invasive test with 95% positive predictive value and 90% of negative predictive values. Cardiac sarcoidosis is a serious complication with a poor prognosis, and CMR considered more sensitive as a diagnostic. In left ventricular non-compaction, CMR has a superior acoustic window to visualize the apex rather than the transthoracic echo. And thank you for your attention. And thank you very much.
I think our talks are finished. I'll request the speakers to come to the stage to face questions from any.
You can take it.
I'd like to request Dr. Anup to hand over the Speaker Association certificates and mementos, please.
So any questions for the speakers from any side?
Can you give him mic? Thank you. Yeah, just in case they can't. Can you repeat the question, please?
Sorry?
Can you repeat the question?
Yeah. Regarding the first case in your first presentation, you presented a case with bilateral ventricular hypertrophy, LV and RV, and it was referred to you to exclude, any disease, and you refer back to the clinician to do a workup. So how you refer the patient with back, because usually the cardiac MRI is the gold standard and the last resort for the patients who have diabetes and infiltrative heart disease.
Yeah, so, but if you have we've ruled out the causes of structural causes by MRI that cause RVH, which is the pulmonary valve stenosis, as I said. And indirectly, we looked at the pulmonary artery and it wasn't dilated, but we cannot measure by MRI the pulmonary hypertension. So in this category, I have RVH, hypercontractile right ventricle, but I cannot assess the pulmonary hypertension. And as you know, pulmonary hypertension is a long category of causes. Probably patient has systemic inflammatory disease that we don't know about it. Am I right? So if you go to the pulmonary hypertension, you have a different category of disease that cannot be assessed by MRI.
But in this case, the LU was also hypertrophied. So
The left ventricle, yeah.
Yeah. So, it is not explained by
in
some-
MRI, you saw the presentation. So if there is a suspicion of hypertrophic cardiomyopathy with the fibrosis, that could be diagnosed by MRI. But for this patient, he didn't have it. But as I said, genetic, I haven't said that, but genotype and phenotype is not the same presentation. So you could have a genotype positive of HCM, but doesn't have the phenotype of the disease.
Do you
So
think this patient may have any sort of infiltrative disease?
infiltrative, no. For his presentation at the initial assessment, he didn't have this. So either you diagnose it with the pulmonary artery hypertension and you follow up the LVH later on. If he has, for example, fibrosis down the road, you can repeat the study in 2 years.
I'm sorry.
I may put that in a slightly different manner. When we started doing cardiac MRs, cardiac MR gets sold to the clinicians as the messiah of all investigations. It will give you all the answers. And the truth is that in some cases, you will not get an answer. Okay, you will not get an answer in some cases. It's the truth. For example, you get cases with restrictive physiology who have got hypertrophy, but there is no infiltration. So there is a restrictive cardiomyopathy, but on the phenotypes that we are seeing, we don't see anything. It could be early hypertrophic cardiomyopathy, which doesn't have any fibrosis. It could be some sort of infiltration, which hasn't caused fibrosis. So usually what we say is restrictive physiology, repeat after 6 months to a year time, and hopefully by that time, there is some sort of fibrosis which is established, so we can give you an answer. So if you send me 100 cases, 95% of them, we will get an answer. There certainly will be 5% of cases where the case will come back to you and say, I'm sorry, I can give you a little bit information, but I can't give you a diagnosis in that. That is something which will happen with cardiac MR.
Okay, thank you so much. Another quick question, please. I'm sorry, the time is short. For the ARVC, you mentioned that there's positive drops, for multiple times. Can you correlate this positive drops with the ARVC? Is the ARVC for the ARVD, if it is an inflammatory disease, is usually troponin is positive in ARVC or ARVD, please?
I couldn't hear you.
In
So positive troponin, yes?
in ARVD, can you explain the drops in ARVD?
The case presentation, I was talking about that. A patient presented with positive troponin, and he has ECG of T-wave inversion, and he presented with syncope. He lost conscious, and apparently we recognize that he might have an ventricular fibrillation. In this context, you don't take troponin and myocardial fibrosis as a diagnosis for myocarditis, where in other cases, with other different scenario, it could be the diagnosis.
This is an inflammatory disease?
What is it?
ARVC is an inflammatory disease?
No, it's not an inflammatory disease. It's a genetic inherited disease that you get a genetic gene mutation. This gene mutation causes the right ventricle to have a fatty infiltration.
And then fibrosis.
Yes.
In ARVC, it's not necessary to get a troponin rise, and it's a congenital disease. You're born with it. So that's why you do ask for, when you have an arrhythmia, like where electrophysiology comes from, you ask for right ventricular study using a CMR so that you can actually exclude ARVD, sorry.
Yep, okay, thank you.
Excuse me, I have a question. You have a patient who's young, has borderline hypertension, but you have hypertrophy on the echo. Is a CMR able to give some guidance in these patients, especially if they are doing good number of exercise, or you're thinking of, uh, any idiopathic cause of this hypertrophy? Does the CMR really give you an answer in these subset of patients?
So yeah, we can have MR. We do MR to assess the aortic root, and if the aorta is dilated, this is more or less with hypertension. Is it symmetrical or asymmetrical hypertrophy? This is you can get by the MRI. Other form of obstruction, which is go with the hypertrophic cardiomyopathy. And nowadays we do T1 mapping, but we haven't reached to a cutoff. T1 mapping, we are trying to differentiate between HCM and aortic stenosis and hypertension in terms of differential diagnosis. So down the road, yes, clinical history, you cannot answer everything by MRI. So there is a rule, we can give you primary answer, but if you're still suspecting, if you have ECG finding, for example, T-wave inversion with hypertrophy, then you get more to the HCM, and then down the road, you can repeat the MRI and see if there is a fibrosis along. Okay.
Thank you.
Just a question in relation to that. If we do septal ablation for these hypertrophic cardiomyopathy in relation,
Yeah.
does it actually come up as a scar tissue? Do you actually, is it CMR, follow-up CMR actually advisable?
A follow-up CMR.
Yes, scarring.
Yeah, so as I said, if you have HCM in elderly, then it's not carrying a poor prognosis, but it's if a young age patient, then you have to think twice before you say that this is only hypertension. Do the risk stratification, look at the ECG, and if you need to repeat CMR, actually in my center, we used to do a follow-up for the HCMR study actually. So
after septal ablation.
For?
After an ablation, alcohol ablation.
Yeah.
If I rephrase the question is that if there is a utility of CMR in a patient who has got a septal ablation after hypertrophy, in a patient hypercardiomyopathy.
To follow up the septal.
Follow up for example, to quantify is the sublation effective? Did we damage enough tissue?
Yeah, actually, if you want to see the thickness of the septum, yes, you can do that. Yeah.
It's advisable to do a follow-up.
It's advisable because actually you have a superior acoustic window. You can see the whole myocardium. So yeah, you can do that.
Yeah, because you get referred a lot of cases like this in your.
Because what happens is the fibrosis secondary to septal ablation. That's what I want. You will see it. And the question is, can that become another BTDF focus for you in the future? The answer is we do not know.
Okay, that's what I wanted to know. That was the thing. I mean, can you actually alienate the fibrosis and then actually say that, okay, this is going to be a problematic trauma or not?
This is higher, actually. This is another research they are doing to quantify the link enhancement and correlated with the VF.
If it is a clinical data of septal ablation. If we take the clinical data of the patients who undergo septal ablations, the incidence of arrhythmias are not that huge for us to use a CMR to determine which patients will eventually have an arrhythmias somewhere down the line. The clinical data is reasonably good for sublation if done properly, because we actually look to an angiography, we define which artery is a big one, and we temporarily occlude the balloon to see if there is a gradient, and then only we ablate it.
So two things which Yasmin just mentioned. So currently, if you look, there is very good evidence that before doing anything in HCM, if the fibrotic burden is more than 50, then they are poor prognostics and they need a CRTD. Okay, that's one side of it, the 15%. So if you're doing a cardiac MR before ablation and then do a cardiac MR post ablation, you at least have something to say, this fibrosis was not there before, it's there now in the area of your ablation. You can interpolate it that this is related to that. Second thing is, we have moved out of doing septal ablation in our unit. We are gone back to cardiac surgical myomectomies. We are getting much better results with myomectomies, than what we used to get with. We used to do myectomies, Then we had a phase of about 7 years, 8 years of doing septal ablation. And then we've gone back to myectomies because the response was not as what
I
we
have to
wanted.
ask one last question. This hasn't come up. What about the scanning in patients with devices? I know we didn't have that talk, but it's very important as well, especially with old pacemakers, ICDs, which were not conditional. Do you have any experience to share in this region? Because a lot of patients in this region have ICDs put in or pacemakers put in 5 years back, 10 years back, who now need MR. And does it make a difference if you do this MR on a 1 Tesla or a 3 Tesla? Does that make a difference as well?
Of course, yeah. Well, 3 Tesla is contraindicated for any patient with devices, pacemaker or ICD. So out of the table, 3 Tesla. You can do actually a scan in 1.5 Tesla with a patient with the devices. Mostly, we can scan patient even with non-conditional devices. That's our experience. One exception is if the patient dependent. And if the patient has a pacemaker dependent, it has to have, a serious indication to do cardiac MRI. If CT couldn't answer you, then because this is the only category that we don't proceed. Otherwise, you have to work with the technician, and you have to work on the artifact actually with the scan. In cine images, you can just go after the artifact and you can produce good images. But in late GAD enhancement, especially at the apex where the device is there, and you have a very terrible artifact. So you have to change the frequency of your images, and you can repeat further. Actually, this is going to happen with cardiac monitoring, but is it doable? Yes, it is doable.
Can we close the session, Dr. Rashid? Is it okay?
Thank you all. Yeah, so now
I'm just going to invite Dr. Anup to hand over the certificates of application to Dr. Yasmin Hanfi, please.
So Dr. Anup will hand over the certificate of appreciation to Dr. Yasmin Hanif.
Dr. Amrish Agrawal, please. Dr. Hussam Zaki, please. Dr. Antoine, please. Mr. Khalid, please. I'll get it to you. And I request you to hand it over to Dr. Rashid as well. Can you give me
So who will go with honor?
Dr. Yasmin, please be there. We'd like you to be the chairperson for the next session. We have interesting case presentations from yourself and Dr. Vimal. Can I take the opportunity to invite Dr. Vimal on the stage, please, for the case presentations?
Okay, now last session. We're going to make it slightly interactive, guys. How should we do this? Whoever thinks they are closer to the radiology side of the world, come to this table. Come on. I'm not going to individually ask anybody. Everybody, whoever thinks you are part of the radiology side. You three are techs from Karnataka, so I know who you are. Please come forward. Whoever thinks they are from the cardiology side of the world, go to that side of the table. Come on, let's have a radiology versus cardiology debate. Come on, now, I'm not going to ask you any difficult question. Come on. I know you are techs, you do some echocardiography. You're going to put together your knowledge and we're going to see some cases. Come on, come forward, come forward. Munde banni, sir. Banni. Nachke padbedi. Anton, you're radiologists. Come and help them. You got to help them. Come on. Let's get together. Okay. So you guys decided to go with the cardiology side. Come on, come forward, come forward. There's one table in the middle. Which side are you guys in? You're on the cardio. Go on to that side then. Let's go on to that side. Okay. Open book, open Google, open phone. Whichever way you want to do it, we'll do it that way. Okay. So what I'm going to do now, I'm going to play some cases. Okay. A lot of it, you open your mouth. You don't get the marks, others get the marks. Okay? So I'm going to start off. I'm going to give you a little bit of a history. I'm going to put this all up. I don't want diagnosis. I want very simple, very simple things I ask. Things like this looks dark, this looks white. Nothing technical, nothing medical. So this is a 40-year-old male patient, okay, who came in with chest pain, which was atypical. And we did an ECG and we found something. We found something. I'll not tell you what we found, okay? So I'm going to give the, oh, you get negative marks. Remember that? I'm especially very supportive of the radiologist. I'm very biased. So, okay, final discretion is with me. I know we have Yasmin there with me as well. Okay, so for the radiologist team, what do you see? Do you think there's something abnormal? Can you see the left ventricle apex? Yes? Look, can you see the blood in the left ventricular apex? So what does the blood look like? Blood looks something like this. This is the left ventricular apex. Do you guys, can you see left ventricular apex blood? Yes, no? No. Okay, good. Well done. That's good enough. Cardiologist, now your opportunity. Tell me, what do you think? What do you see? Hypertrophy of the left ventricle, okay?
Apical obliteration. Okay. And right ventricle looks mildly hypertrophied as well, to be honest.
Okay. Right ventricle also looks. So what we are looking at in this case for the uninitiated eyes is that usually this is what happens. You can try and see here. The myocardium should be as thin as this or as thick as this. But as we go towards the apex, the myocardium is really thick. It's very thick. And that's what is LV hypertrophy. Another thing what's happening is as the ventricle contracts, I'll just stop here. Ventricle, when it contracts, you can see that there is no blood pooling. There's no cavity left in that. So that is called as a cavity obliteration. Okay. Apical cavity obliteration, hypertrophy of the muscles is all pointing towards a diagnosis of apical hypertrophic cardiomyopathy. Okay. Now, what is the importance? Would cardiac echo not told us that? Cardiac echo would have probably given us the answer. But what cardiac echo may not tell us is what I'm going to show you now. In here is the delayed enhancement imaging. So in delayed enhancement imaging, normal myocardium should be what color? Cardiologists. Black in color. Perfect. Are you guys seeing everything black or is there any white spots? There are some white spots. Yes, you can see all these white spots inside here. This is fibrosis within the hypertrophied muscles. So what does that mean? That there is fibrosis. Now, why is that important? These are areas of scar. These are areas which give rise to arrhythmia. They give arrhythmia and patients can have problems with that. Remember, the thing that you need to know, a scar of more than 15% is poor prognosis. A scar of more than 15% is. So this is apical hypertrophic cardiomyopathy. Any questions on that? Case, and I'm not going to talk to you about it, and you guys are going to give me the answer. So for the cardiologist, they should be able to give me the whole answer. For the radiologists, you're going to tell me bits and bobs of what you see. Not yet. Not. I'm going to give you some time. Okay. The radiologists say mitral regurgitation. That's good. Cardiologist, you can't wait because you know the answer. That's why you can't wait. I know that. Okay. So is the muscle hypertrophied or not? Aorta is very small. That may be just the projection in the way we've taken this. So this is all hypertrophy. What is happening to the cavity? Cavity is getting obliterated. Yes, like what we'd seen in the last case, but it is diffuse. It's pretty much everywhere, correct? Now, cardiologist, please tell me what you're seeing.
Motion. We see systolic anterior motion. We see moderate mitral regurgitation.
Excellent. Okay, so what we are talking about here, just look at this mitral valve. The mitral valve moves anteriorly, and you're getting this flow turbulence across here. This is called as the SAM, systolic anterior motion of the mitral valve leaflet. And what is happening is that there is narrowing of the blood flow from here, and that is LVOT obstruction. Okay? Mitral regurgitation, can you see the jet here? Small jet coming across here. And there's also a small jet which is coming across here, which is the aortic regurgitation. Can everyone see that? So, HCM, poor prognostic features. I've told you one already, which is that 15% fibrosis. Poor prognosis means patient will do badly. A hypertrophy of more than 3 centimeters is poor prognosis. Okay, if the muscle wall thickness is more than 3 centimeters, it's poor prognosis. Third poor prognosis is cavity obliteration in diastole. Now, what are we looking for in delayed enhancement, radiology team? We're looking for areas of fibrosis. We may find some fibrosis or we may not find some fibrosis. So let's just look through and see. Yes, people are happy. You can see this mid-myocardial fibrosis, which is extending across here and here. So this again actually is less than 15% of the myocardium. So it's not a bad prognostic feature. Good. Now, I'm going to go. Please. Yes. No, we have a software which basically creates. Manually, we will not be able to do that. But we do have software, yes. Now, this is an interesting case. If you were listening to Yasmin's talk, then you're going to be able to answer this. Okay, so both the teams. Look, if you only give me one answer, there are 2 pathologies in this patient. So I want 2 pathologies. So I'll tell you there is no hypertrophy in this case.
Look at the size
No
of the RV.
hypertension.
Or
Can we have a go?
Right ventricle, let's see. What do you guys think about right ventricle? Dilated, okay, fine. Do you want to add on to
I
that
want to add
dilatation?
this is partially thinned out, the wall of the right ventricle, and you can see areas of dyskinesia all along the RV free wall. You can also see an area of dyskinesia along the LV apical area.
Can you see this, guys? This is dyskinesia. You can see small aneurysms poking out here in the RV free wall. Every time it contracts, it kind of, things go out. So these are called microaneurysms of the RV. Anything else?
The right atrium is dilated, you know. And
Fine.
the right side
Atria is dilated. There is mitral regurgitation. There is tricuspid regurgitation. Anything else?
The LV is poor, actually. The compaction is poor in the LV.
So there was a very good point raised here. It said, is there an ASD?
No, I'm not sure.
No.
So, the
So
thinning
this
of the-
is one of the problems of cardiac MR, that this may appear like an ASD, but it is not an ASD. That is not an artifact. That's just the way it looks. Now, this patient came in with a history of coronary artery disease, and you showed that they had coronary artery disease. But then later on, they came in with a VT, which is what prompted ventricular tachycardia, which prompted the cardiac MR, which led us to find this area of abnormal aneurysmal outpouching, okay, which is basically suggestive of ARVD, arrhythmogenic right ventricular dysplasia or cardiomyopathy. Now, I'll just show you another area. So this is another way of looking at the RV, and you can see here, this inferior part of the RV is bulging out every time the heart contracts. You can see that is just coming out. This part of the RV is coming out. So the second pathology which I was expecting you guys to pick is shown on this bit of delayed enhancement imaging. Radiology team, what do you guys think? Normal, abnormal? Good, well done. Cardiology team, tell me what's the abnormality? Inferior wall scar. Can you see that inferior wall in this two-chamber view now?
You can partially.
Yes. So
Partially.
you can see that it's thinned out here.
I can
Okay, good. Inferior wall, perhaps you wouldn't see very well on the four-chamber. You would want to see in the two-chamber. So in here, you can see this part of the myocardium is thinned out. It's not contracting as well as this part of the myocardium. And that is all area of infarction in here. So this was a patient who had an RCA territory infarction, okay, who had a catheter angio in previous admission, and they said there's nothing we can do to the RCA territory, leave it alone. The patient went home, came back after a VT episode, and then they sent them for the cardiac MR, and that's when we discovered ARVD. Yes, sir.
And now we have got we have an inferior MI.
Yes.
And why we think this RV is not infected RV along with the pathology of right coronary artery lesion.
Why? Okay, fine, good point. I'll
Actually,
tell
I
you.
got something that we have to quantify the right ventricular volume. So we described regional wall motion abnormality, but this is only one criteria, and you have to have a complementary quantitative assessment with the index in diastolic volume. So two criteria, this is major, then you cannot say, oh, I can bypass and say this is not ARVD. Yeah, carry on, Dr. Brahmi.
So, yes, for us to call it ARVD, we can give you one major criteria based on the RV end diastolic volume. Why is this not infarction? The reason we believe it's not infarction is that the amount of delayed enhancement you would get as part of RV infarction would be much more than what we've seen in this case. Otherwise, we would, it's a good suggestion there. Okay, now this time I am going to try the cardiologist in their own game. Interventional cardiologists. Okay, young chap. Okay, young chap. I'll not give you the RCA was normal. Let's just presume that. Okay. This is not the sequence of events things happened. The patient had an echo that led to a cardiac MR, and then that led to this catheter angio.
There is a probably a fistula. Camera.
Okay, so you think there's a coronary cameral fistula, which is there. Okay, fine, good. So what we are looking at is in this area of things, actually, there is pooling of contrast, and one can see across here. So there is a pathology. Let me tell you that it wasn't a coronary cameral fistula, and I'll show you cardiac MR. Okay, very good. So that was the clinical suspicion, and it was felt that is there a tumor there? that we need to look at.
I just have a quick question here. Does
Yeah.
this tumor begin in the myocardium or is it extracardiac? And it's
So have a look, have a look. It's all the images are next to you. So this is a edema, myocardial edema sequences, and you can see that this is heavily T2 weighted or heavily fluid weighted sequence. And this is the pretty much similar signal to myocardium. And the answer to your question, Amit, is that yes, it is within the myocardium. So echo showed this mass. It was a little hyperechoic compared to the myocardium. And we looked at this and said, hey, okay, we'll do a cardiac MR, and we do this. And we got the answer in this one particular sequence. This is a perfusion sequence that we're going to run now. So contrast is coming through, and we are looking and see that the contrast is basically filling in the cavity.
So it's a vascular structure. There is an uptake.
Ah, radiologist got the answer, guys. $5. Okay, so this is important. So one of the questions that comes is this communicating with the LV cavity or not? That's one important question. So it's I'll make it slowly go through contrast. Okay, now contrast coming into the right side. This is coming into the right side. Then it is coming into the left ventricle, not into the mass, not into the mass, not into the mass, not into the mass. Now, by this time, the contrast has gone into the aorta. And from the aorta, from the coronaries, the contrast is coming in to this. Not with the LV cavity. It's not communicating with the LV cavity. So this was a case of delayed enhancement also. I'll show you. This is the delayed enhancement, and you can see there is good amount of delayed enhancement in this. So as Anton said, this was a case of cardiac hemangioma. It was a case of a cardiac myocardial hemangioma, which gets this contrast filling in through the vasculature. And we basically treated him. We tried to treat him with looking at the feeding artery, and we put some embolization and clips. By a follow-up study in 6 weeks, many other vessels had developed, and the size of this hadn't changed at all. So it wasn't a great mode of treatment for us. So let's look at this one case. Okay, this is something we come across often. So this is a patient who has come in with very non-specific symptoms of chest pain and increased fatigability. Okay, and a few things that we can see at the start itself is that you're seeing this tricuspid regurgitation. We're seeing this mitral regurgitation in this, and I'm going to show you. So question which got asked to us at that time was, has this patient got any myocarditis? So for myocarditis, we would do this specific edema imaging. This is from an era where we didn't have mapping with us. And you can see this is the normal myocardium, and then there are some areas of increased T2 signal. And then we do delayed enhancement imaging. And on delayed enhancement imaging, we're seeing this kind of multifocal areas, some mid-myocardial, some endocardial, some epicardial enhancement in this region. So not something I would expect you all to know off the top of your hand, but something which if you are starting to see in your institute tomorrow, you need to know the differential diagnosis for this. So young guy with what looked like myocarditis clinically, and you're seeing these patchy areas of enhancement. What would you guys think, cardiologists? Yasmin? Oh, you'll go to Yasmin, he says. Excellent.
Myocardial fibrosis,
Fibrosis, yes, but that's a very generic term.
sarcoidosis.
Okay, very good. So that sarcoid is one very, very good in the scenario that we are in India and probably in here. I would add something else along with sarcoid.
Amyloid. It doesn't look like amyloid. No?
TB.
Tuberculosis.
TB. So we get a lot of myocardial TB without pericardial involvement, which looks like this patchy areas of fibrosis, which may have transmural involvement, some epicardial, some myocardial enhancement. So that was a case of TB. You guys have heard of endomyocardial fibrosis,
Can
yes?
I just ask you this question?
Yeah.
This follow-up of this patient, when you do a CMR after a full course of ATT,
Hmm.
does this regress or do you have
The
any-
edema comes down, the fibrosis goes down, but still stays there.
if you had history of tuberculosis in the past and you had a CMR for whatever reason and you find this, it can correlate with old history of COX.
It can correlate with old history also, yes. But the amount of fibrosis is not that extensive in that period of time. But we find a lot of sarcoids in that manner. So when you have a patient who comes in with VT, VF out of nowhere, get a cardiac MR done, you will find areas of fibrosis like this. You suspect sarcoid, get a PET CT of the body done, and you do a PET CT to look for other areas of sarcoid involvement, which you can biopsy, basically. So that is something which is very common enough. Now, this is a very interesting case. This is, I think, the second last case, which I'm going to show you guys. And this was a patient. And this is like a gold medal case. If you guys get it, very good, because I was very impressed when I got this. This is a patient who comes from an endemic African nation where endomyocardial fibrosis is very rampant. Okay? And it was referred to us as endomyocardial fibrosis. So for others who think endomyocardial fibrosis, essentially the left ventricle and the right ventricle, the apex starts to get obliterated and there is a lot of fibrosis within the LV and RV apical cavities. So the cardiologists think they know the
think it's
answer.
a non,
There is no late gadolinium enhancement.
the non-compacted LV.
Non-compacted LV, okay. Good guess. Unfortunately wrong.
Can we have that late GAD picture?
Yeah, you can have. No, this is the cavity within this.
Okay. So this is non-ischemic enhancement, right? On the
There's no enhancement.
there's no enhancement.
There's no enhancement. There's no enhancement. Sorry, I can hear a voice, but I can't hear what that voice is telling me.
Eosinophilic
I'm going to show you the short axis images of this patient.
Oh.
Yep. Eosinophilic cardiomyopathy. Again, the peripheral eosinophil counts were normal and there's no enhancement, so we wouldn't. So this is a very tricky one.
Yeah, the
okay?
pericardium doesn't move with the pericardium doesn't move, you know, you see the
Pericardial effusion, there is trace pericardial fluid, I agree.
Abnormal papillary muscle. Then-
Abnormal. Okay, that's a good.
Yes.
That's a good guess. Good guidance, actually.
Okay.
This is a case. I'll give you this black blood
Mhm.
images for you to just see the normal anatomy. This is the aorta. No, that's the pulmonary artery, and that's the aorta. So
Okay. No, the aorta is rising.
the aorta is very.
So the rising of the aorta, if you go further up,
Mhm.
you see. It's anterior, is it?
Good, very
Yes.
good.
So the aorta is anterior now.
So the aorta in this case, usually, if you guys remember the anatomy, when we see like this, pulmonary artery is usually here and
So
the
what is
aorta
it?
is usually here, but it is the other way round here. So Amit, what's the answer? You just said it.
Dr. Agarwal said CTG.
Is it?
Anterior.
So this is congenitally corrected transposition of great arteries. What does that mean? Is that this is actually the right ventricle of the patient. This is the morphological right ventricle. This is the morphological left ventricle, which have switched across.
African history, that was.
I am being very honest. This is one of the cases from Nigeria. It's a good friend of mine who learned from us, and it goes there. And he says, "Hey, this came across as a EMF. Looks like that, but there's no delayed enhancement. How is that possible?" So I looked at it. I was like, if you see all this, the clue comes in.
What
This
the
is an
transaxial. Yeah, sorry. Yeah.
this one is also a clue. This is a very abnormal morphology of the ventricles. This is one supero-inferior relationship of the ventricles, which tends to happen in congenital heart disease. Usually what happens is you're seeing the LV and RV like this. In normal, it's like this. Okay, this is how they contract. In this case, it is like this. So, and of course, as Yasmin picked up, the clue is here that the aorta is pretty anterior.
So that's why when I
in the-
said that when you assess the right ventricle, you have to go with the transaxial synestax. So by four-chamber view, you would not pick up the diagnosis, but running through the transaxial synestax, when you saw the aorta, you got the diagnosis.
So this is something, and this was an unsupervised scan. They just did a standard protocol for LV cardiomyopathy, and we got that in there. Last case. This is a patient with coronary artery disease being assessed for viability. So this is something, viability, I believe, is probably the number one test. If you're going to do cardiac MRs for, you should start doing it. It's a very, very nice test. It's a very simple test for us to do, and you will get very good results as well. So what are we seeing in here, guys? Radiology team. Old MI, excellent, okay. Sir, sorry? VSD across here? Is that, no, it's normal, it's thinned out myocardium, no VSD. It's dyskinesia. Everyone can appreciate the apex bulging out across here. It's not doing what it is meant to be doing. So what do? We get a delayed enhancement images, and we get delayed enhancement images, and you can see that the entire myocardium across here is dead. Okay, so this is, we live in a society where we get a lot of late presentations of such infarcts, and you can see this is a huge LAD territory infarct, which is going all the way up to the apex. So in summary, reporting of cardiac MR is relatively easy if you have some basic knowledge. You can acquire this knowledge if you're in a decent volume center and put in your efforts. Acquiring the images, where you guys come in, that's the hardest part for cardiac MR. Acquiring the images, getting a good quality cardiac MR is difficult, but it is very, very important. If you get a good quality cardiac MR, the reporting side becomes very, very easy. So thank you very much for participating.
No, it's
Radiologists
interesting,
have to
really.
win it. If there are any questions, I'm happy to take.
I just have one patient. I wasn't ready actually, but I will show you some unexpected finding. Thank you. Actually, you can pick up the diagnosis for radiologists, sorry, for cardiologists and radiologists, because this was an unexpected finding in CMR, actually. So what is the story of this patient? Patient came for MRI, and actually history is he's a Marfan case. He has a aortic root repair, and usually we do a follow-up scan for the aortic root annually. So he came for his annual checkup by CMR. He was in a hurry. Please, doctor, I have a flight. I want to catch this flight. And he was the last case scanned in Friday. So he was the last case. He was flying, and we were scanning this patient, and then so okay, I hope this is a video. I think this is a video. So this is the aorta, and I mean this is a assessment of the aorta. The aortic root was repaired and determined to assess the aorta, but there is something else just nearby the aorta. It's quite dense, and we were suspicious about this. So what is usually the anatomy here? This is aortic root, this is left side, and this is right side. What do you expect to see in this side, radiologist? Yeah, please. Exactly. So we were like, oh, is this an artifact? Is this truly where the RCA is supposed to be? And then we went and saw this. This is the left, this is the right ventricle, and here is the huge mass. So what is it? It's easy, actually, but unexpected. Exactly. So that was an unexpected finding. And again, we saw that in different images. Sorry, I wasn't really prepared to do that. So unexpected finding, RCA aneurysm. We went back in the history, and we found that patient has an episode of chest pain, and ECG was sinus bradycardia. He went to emergency room. He was assessed. ECG was only slow heart rate, nothing else. Troponin was negative, and he was discharged. And then we came back afterward and retrospectively analyzing that this could be the bradycardia presentation of the RCA. We called the cardiac surgeon, actually, immediately. We asked him to cancel his flight for me. So a cardiac surgeon, and then he went and he had the full assessment of his coronary artery with the cardiac CT, help of cardiac CT. So we pretty do not bad in a cardiac MRI in assessing a coronary artery disease. And this is only just a case to share with you. And thank you all for that.
So I want to thank everybody, all the speakers, all the attendees, and everybody from the pharma industry, everybody from MarVision for arranging the sessions and making sure the event went without any glitches. I hope we have a future event in the next year or maybe the year after that. But thank you all very much for making it a very good day, and we learned a lot. A special thanks out to Dr. Vimal and Dr. Yasmin. Thank you.
We'd like to thank you very much, and also I would like to thank Dr. Amit for all the efforts extolled during the preparation and the preparatory period before this event. It's like preparing the wedding of your son or your daughter. It's very complicated, and you have to invite everyone, and you have to make sure that the food is good and the material presented is good. Thank you very much, and hope to see you in future instances. Thank you. Yeah.